Okay, Chair, you're now live.
Thank you. Good morning, and I'd like to welcome all councillors, officers and members of the public viewing on YouTube to this meeting of the Children's, Adults and Health and Wellbeing Development and Scrutiny panel. My name is Councillor Vic Pritchard and I'm the chairman of the panel. I will now call out the names of other members of the panel and ask them to confirm that they are present. So I'll start with Councillors Michelle O'Doherty.
Present.
Jess David.
Present.
Ruth Malloy. Ruth Malloy.
Unmute.
Sorry, yeah. Yes, I'm here, present.
Thank you. Lucy Hodge. I don't know that we have Lucy present.
Chair, no, Lucy should be with us hopefully by about 10:30.
Right, fine, thank you. Mark Roper.
Present.
Andy Waite.
Present.
Paul May, as I understand, has given his apologies. Liz Hardman.
Present.
And the panel also has 3 co-opted members, and they are David Williams.
David sent his apologies today, Chair.
Right. Chris Batten.
Yes, present.
And Kevin Burnett.
Present.
Thank you very much. Also present are the report authors for the items of today's agenda, and they will be introduced as we make their way through this agenda. Can I remind members and officers to keep background noise to a minimum, to only speak one person at a time and not to speak over others? Please mute your microphones when not speaking and then unmute when I invite you to speak. Please indicate if you wish to speak by using the chat facility on Zoom. We've already been through that. We'll actually do hand signals and I will call you to speak in turn. If a member of the panel has to leave the meeting, then please draw my attention to this using the chat facility or hand signal. If you subsequently return to the meeting, then please also draw my attention in a similar way. Members should also inform me if they lose connection and miss any part of the meeting, as they may result in them not being able to vote on any item they do not hear in full. Should the panel need to take a vote in order to expedite the result, I will assume majority position. So if you wish to abstain or vote against, please indicate this by the chat when we move into the vote. Does anybody have any further questions? No. Then we'll move on to item 2. Is anybody getting this disturbance, this noise? Yeah.
Yes, Chair. I think it's somebody might be typing or looking at papers and still have their microphone on. So if everyone could just check that they're on mute and when not speaking, that'd be great, please.
Chair, I've just muted them, so there shouldn't be a problem.
Thanks, Mike.
Right, thank you. So we go on to item 2, apologies for absence and substitutions.
Yes, Chair, just to confirm, we've got Councillor Lucy Hodge said she hopefully be with us by 10:30. She's subbing for Councillor Barrett Pancania. And you said earlier, yes, Councillor Paul May has sent his apologies, and also David Williams has sent his.
Right, fine, thank you. Item 3, declarations of interest. Are there any declarations of interest? No, none to be recorded. Any urgent business agreed by the chair? And what I'm going to ask now is Adoption West Joint Scrutiny Panel. There's a need to an appointment of a non-executive member, and I'll ask councillors for nominations for a non-executive member to sit on the panel. Do we have any nominations, please?
Chair, I'd be happy to nominate myself for the position.
Right, can that be seconded by someone, please? Right, that looks like Liz Hardman's done that. So thank you, Michelle. You're co-opted as in the appointment of a non-executive member for the Adoption West Joint Security Panel. Thank you. Item 5, public councillor statements and questions. There are none. So item 6, the minutes of the 14th of July 2020. And can we take those as a true and accurate record? Can I have a show of hands, please? That looks as though it's carried. Now there are some matters arising that coming from this. Can I understand that, Kevin, you have some that you'd like to bring to the attention of the meeting?
Yes, please. On page 6, I believe, and item 6, the first paragraph was asking whether the Secretary of State on the issue of funding pressures in the education system, whether there was a reply back or any more information, and also, if not, whether we could press them again, bearing in mind that the pressures on the system have increased dramatically given the current COVID situation and the additional cleaning and protective measures that have had to be put in place.
So we're asking for an update from the officers. So if that could be recorded, please. Next, Kevin.
Sorry, yep.
Page 7, is it?
It's page 7, is it? Sorry.
Yeah.
I'm flicking between two screens. I do apologise.
Right.
It was the
Was
I've
it on
lost
COVID?
Yes, on COVID financial commission services, beg your pardon. Yes. Dr. Bryn was very kindly going to find a response whether there was what the impact may be on the commission service and whether it was Dr. Bryn now, but somebody was going to find the impact and whether St John's Foundation was going to cover the problem with the commission services.
Right, so if we can get further information from that, there can be a further response, that would be appreciated. I'll take you on to page 10 now. And Kevin Burnett, in that instance, you asked if there was any further comment to be given on the impact of the current situation we have on commission services. The cabinet member said he would share the information with the panel once it had been confirmed. As of yet, we've not received anything. So again, can that be highlighted so that we do gain a response? And further down on that same page, Councillor Eleanor Jackson, she was concerned that pupils from Radstock that attended Kilmanson School in Mendip have received no form of education since lockdown, and said it appears unlikely to reopen in September, and asked what could be done to help those pupils. The Director of Education responded by saying that he would follow up to find out further information in relation to local pupils attending Kilmanson School. To date, we've not received any reply on that, so if that could be attended to. Are any other members of the panel? I think there's a concern, and I think Andrew, Councillor Andrew Waite, you had a query on page 15.
That's correct, yeah. On page 15, I asked a question about the dry runs, which was identified in Annex A of the report, but Annex A was not part of the documents, and I asked if they could send that information to me, and I don't believe I've received it.
Right, so if Andrew could have that information sent to him, and can all panel members share that information, please? And I believe that's all of the matters arising. Is there any other members can see anything, identify anything, or are you satisfied with it as it stands? It appears that that's all been dealt with. So if we now can move on to item 7 and the cabinet member update. Now we've got two. Have we got both cabinet members present? I thought I saw Rob Appleyard. Yes, I've got. Oh, yes, both are there. Yes. Right. Now, we've got a bit of a problem, if I can put this to you, that we have not received a cabinet member update from either of you, which is, to the best, it's disappointing, because we do like these ahead of the meeting so that we can reflect on the content and form questions if we see it appropriate. But we've been denied this opportunity because we haven't had anything this time round. I appreciate that these are written by officers, but I do feel it's your responsibility as the cabinet members to prompt your officers into making that report for the benefit of this panel. So please accept that as a reprimand, and we'd prefer it didn't happen again. Okay, so which would two of you has something to present to the meeting? Who's going first?
I don't mind going first, Chair.
You are top of the screen as well, Kevin. So.
Well, first of all, I apologise, Chair, and I apologise to the committee. We've had a change around of senior management within the department, so that might have led to a little bit of confusion about who's doing what. So I'll make sure that doesn't happen again, Chair. Right, welcome. Hello, everybody. Well, I'll go straight into my report. As you'll be aware, all schools have opened and all pupils in Baines are attending. Schools have completed necessary risk assessments and are working through new ways of delivering education to minimise COVID-19 infections. Attendance rates are looking very positive, with schools seeing pupils return as expected. Maintained schools are seeing attendance rates between 90 and 98%, and local authorities will be analysing the data with all schools across the authority later this week. The local authority has been producing a newsletter for all schools with relevant information on government guidance on how to access services to support vulnerable children. Additionally, the local authority has provided schools with a transition document designed to support children's wellbeing and mental health, which I'm sure you'll all appreciate is extremely important. Children's Social Care has set up a dedicated helpline for schools to enable schools to access advice and support from a social worker during the period of 12:30 to 1:30 every day. They have provided a business card, detailed contact information, together with a poster. This has been placed since the 7th of this month. Local authorities believe it has resolved most issues with regards to transport for children to school. This also includes replacing public bus routes for some schools to deliver dedicated transport. Schools are being encouraged to ask parents to encourage walking and cycling to school wherever possible. And I will be sending out a letter this week to all head teachers to remind parents that this is in the best interests of the local environment and their students' health as well. Public Health England South West have delivered a rolling programme of webinars for schools on managing the outbreak based on PHE's notification pathway for education and childcare settings, which have been widely promoted to all schools. This will include a large exercise later this month with local schools to go through scenarios even on how to manage any outbreaks. Additionally, Children's Social Care have considered the revised Ofsted guidance and have increased preparations for a possible Ofsted visit in the period between September and December this year. Youth Offending Services have also increased their preparation for a YOS inspection, as two neighbouring local authorities, North Somerset and South Gloucestershire, have been inspected in September 2020. I had sight of questions Liz Harman's posed with a complaints report, and I will forward my response to Liz. Thank you very much, Chair.
Right, thank you, Kevin. Can you send that to all members of the panel? I know it would be retrospective, but it will give us all a chance to reflect on it, because having it verbal, we're not going to catch everything. Liz,
Not a problem, Chair, I'll do that. Yeah.
Liz Harman.
Hi, Kevin. Thank you for that. I just wanted some clarification about the protocol for schools. The guidance from the government is very unclear about this. What happens if a pupil is identified as having COVID-19? So what are the protocols that are in place? Now, maybe this is not for you. This is for item 10, public health, from Bruce Lawrence. But I just wondered, so what have schools been told? I mean, you know what our maintained schools have been told, and I'm assuming that's going to be the same as our academies.
That's correct, yes. Bruce or Chris might want to answer that question directly.
Hi, I can pick that one up. That's okay. So, I mean, all schools have been given advice regardless if they're maintained or academies, and we spent quite a lot of time in the final term going through scenarios about what would happen, and that was done online and via information that we provided on our web pages. We produced a flow chart for every head teacher. We've done checks to see if they understand what they should do. The first thing that would happen if they're notified of a positive test is they would speak to the health protection team. The health protection team would give them appropriate advice on what they should do next. That would be completely driven by whether they're a primary school, a secondary school, which year group they're in, which bubble they're in, whether it's a member of staff, whether it was a pupil. And then the health protection team would notify us. I'm informed of every case in the school which is positive. Our fantastic public health staff who are doing a really good job, I think, in supporting schools to do that would then contact the school the next day, and then they would go through local advice. We would talk to schools about how they would correspond with parents. We would talk to schools about how we would manage any press and media inquiries. So there's been a really comprehensive response from public health about supporting schools what to do in terms of managing an outbreak. This is being followed up on the 25th of September with something which we're calling Operation, I think it's Buzzard now, it was Kestrel, I think it might be Buzzard now, where we're doing a big online exercise with multiple members of different schools across the authority from different leadership roles, so we can scenario plan. I think what you appreciate is every single scenario is going to be completely different, and we'll just have to work through it as it arises to the best we can.
Thank you. Kevin.
Yeah, thank you, Chair. Just really, Kevin, to clarify about the transport situation. Do different schools now share similar transport, and how is the transport actually organised for each school now?
That's a good question, and I'm sure you'll be aware, Kevin, that the local authority is only responsible for a certain number of children to get them to school. The other means are to do with the schools themselves. So each individual school and academy have organised the system themselves, and we've worked very closely with them to ensure that all routes are covered. Different buses have been put on for different schools, and I believe certain schools are sharing certain routes. So there will be cross bubbles, I would imagine, on the transport system, if that's the question you're kind of asking there. Obviously, there are strict rules on children wearing masks on buses, and I know there have been a few issues locally where children have not been wearing masks. I've also received a few complaints from residents that children after school have been gathering in large groups on their way home and not listening to the current rule of 6. So I'll be sending out a letter to head teachers this week, reminding head teachers that, and also to remind the parents that their kids should be going home, they shouldn't be congregating in large groups, and also they should be wearing masks when they're on public transport.
Okay, thank you. Michelle.
Sorry, no, I didn't have a question, no.
All right, you came up on the may I speak, so I'll go back to Kevin. Kevin.
Yeah, thank you. Can I also ask, because I'm sure you might find it worrying, we've had some situations from people in schools saying that tests are not available, and obviously the huge knock-on effect on that, both on terms of staffing, if it's a staff member that needs to be tested, and or the children concerned, and the loss of education and time involved all around. How much input do you have on the testing situation in schools, and who are you currently working with to try and get this the best it can be?
That's an excellent question, Kevin. I think what we'll might have to do is give you a written response on that one. From my personal experience, somebody who's also had a test, I find it very difficult, and I think that the staff that are doing the tests are working very hard. However, I think they're overworked. I think the system doesn't work as quick as it should be doing. And I feel very sorry for any member of staff working in a school that can't get a test as quick as they can do. And the whole system does need to be looked at. I don't know whether Bruce later on could give more details on the testing system.
Okay, we'll find out that. I'll go over to Jess. Jess, please.
Thank you, and thanks for the update, Kevin. I wanted to ask specifically about your letter to head teachers around active travel, and linked to that, what can the council do to help schools promote active travel, so walking and cycling into school at this time?
Thank you, Jess. That's an excellent question. I've been contacted by a number of parents recently saying that schools have said that children can't bring their bicycles into school, and this is because of COVID-19 restrictions, which I found very hard to understand as a local authority, and I'm sure we'll all agree that we're encouraging a healthy, active lifestyle for children. So I've also written a letter to head teachers asking how we as an authority can help schools encourage kids to make a more healthier choice to get to school, i.e. more bike racks, etc. So if you are governors of schools, etc., please have a word with your head teachers, pass that on, that would be very useful. If they have any ideas in which we can help them, then obviously we can go to WECA and see if we can tap into WECA's funding stream for cycling and pathways. Thanks for that question, Jess.
Any more questions for Kevin? No, right. So thank you very much, Kevin. We'll wait to see your written report.
Thank you, Chair. Can I just finish, Chair, by thanking all the teachers, parents for getting schools to open so successfully in Baines. I think they've all done an exceptionally good job, and I'd like to thank all the Baines staff as well that have helped out doing that.
That's the thing. I think the whole panel can share that view indeed. Thank you. I noticed that Councillor Lucy Hodge has joined the meeting, so welcome, Lucy. So we'll move over now to the other Cabinet member, Councillor Rob Appleyard. Rob, you again haven't submitted a written statement to the panel, so you share that reprimand, but let's see what you have by way of a presentation for us.
Yeah, thank you very much for your warm welcome, Vic. It's appreciated. And I think, as Kevin mentioned, we have had a change round and everything like that, but we take that on board. But what I will say is that I think hopefully the panel would appreciate that both the Cabinet members associated with the panel do turn up to the panel to sort of stand up to scrutiny, which I don't think happens with all the other scrutiny panels. I just want to cover off several areas if I can. With the recognition that Bruce is joining us a little bit later on, and he will go into more detail regarding the COVID and that activity. And there were questions about testing and things like this. And Bruce will give us the update as he sees it. It's a very difficult scenario at the moment. Just want to cover off an element about our care homes. We've had a slight rise in the number of tests in our care homes. That is not out of sync with what's happening in the southwest, and it seems to be following a slight trend. But when we had this spike, sorry,
we're losing you. I don't know if on the IT background or support, you're breaking up, Rob. Carry on.
Yeah, okay. I'll carry on. As you said, we'll get it in a written form anyway, Vic.
Yeah.
When we had the spike over in the Summer Valley for a number of cases, and the management team of that came together, one of the elements they put in place was to talk to some of the local care homes and put a stop on visitation for a number of weeks, and that was actually successful in actually protecting those care homes to some extent. Just really want to talk about the Compassionate Community Hub. I think we've mentioned this before. It's been a very successful collaboration of not only our residents and our community, but also the partners involved, which is a third sector group, the council and Virgin Care. And just for information, during their time, in addition to the food parcels that went out from government, the Community Hub distributed over 350 food parcels. 72% of those actually went into Bath, and 28% went into North East Somerset. And it's worth putting a bit of context on that the North East Somerset element was also supplemented by the amazing work done by very smaller groups out in their local communities, you know, in places like Porton, Midsummer Norton, Keynsham, where they got together and they actually were working at a very ground level. And the benefit of that is that they were able to pick up some of the other issues that these people were actually struggling with, and that fed into the community hub, who through the process of their pods were able to actually seamlessly help these people. We had a whole range of other events that happened. There was medicine pickups. I think there was over 60 medicine pickups, even hearing aid batteries and things like that, which were very important to those people. They did that. But I think the figure that I find actually amazing, that there's now been over 22,500 frozen meals distributed out to some of the most needy people in our community. And over 5,500 of those were actually children's meals. So it obviously played a significant part on that. Just want to sort of touch on some of the partners that went out. Some of that food got distributed through, and that's places like Bath City Farm, the St Martin's Children's Centre, both the Keynsham and Radstock Children's Centres, and about 17 local nurseries. So it was a truly community and collaborative piece of work that went on there, and something that I know I've had phone calls from my lead members in other authorities asking me how it's come about and how effective it's been. So it's something that we should be rightly proud of. Just really want to touch on, I will touch on an element about the testing. As you know, we've had an MTU, a mobile testing unit, down in Porton Football Club's ground. And I'd like to say thank you very much to Porton FC for helping us and facilitating that. That's been an enormous benefit to the community there. We've also got an MTU now at Odd Down, that's returned there. And we are just waiting for sign off from the government of a walk-in centre that's been identified and checked through by Deloitte's as being suitable. And as soon as we get that sign off, we'll be able to put that out into the public. But I think having the facilities possibly doesn't seem to be the issues at the moment. I think there are organisational challenges that seem to be happening nationally through the availability of chemicals and everything like this. As I said, I think Bruce will actually cover that one off with a more up-to-date position on there. Just really want to then cover off two more points. One is, for a number of years, we've been well supported by a quality of work from Mike Bowden, and who now left us. And I'm delighted that Leslie Hutchinson has now been appointed into that role, because I think Leslie brings an insight and knowledge which actually will help us enormously moving through what I think is going to be a difficult couple of years with all that's going on. And finally, it's now been public knowledge that Kirsty Matthews, the Managing Director of Virgin Care, is moving on to a national post with a large charity. And I would just like to point out that Kirsty came into the Virgin Care in the very early stages of the contract. So she wasn't there at day one. So she had to pick up the reins from quite a complex model. And in that time, I'd just like to sort of say thank you to Kirsty for her honesty in the responses that certainly I've received, which enable us to actually understand what's being delivered and being developed within that contract for our residents. And there's a lot of our people that are actually benefiting for a lot of that work that's happened over that time. I believe, I think the next panel meeting is the 3rd of November. So I think there's one more opportunity for Kirsty, I think, if she's attending on that. So I'd just like to say thank you very much, Kirsty.
Thank you, Rob. You've given a series of acknowledgements there. The acknowledgement of community and how it's faced adversity to really good effect. You've tried to identify a number of organisations in doing that, but in identifying some, you're always at danger of leaving some out. But it's the general the general drive of it is that community has really excelled in this very testing period. As for Les, changing her position, elevated to the Director of Social Care, etc. I don't think you could have a more appropriate person. She's popular and she's capable, and certainly I think everybody can have confidence in her guidance going forward. And Kirsty, I wasn't aware Kirsty was moving to changing post, but I've known Kirsty for a long time and she is very respected in her roles. So in a way, it's sorry to see her go, but these things happen. So anyway, thank you very much, Rob. Any questions for Rob?
Liz,
please. You're on mute. You're on mute, Liz.
Right, done it.
Right. Okay.
I'm still okay. Yeah. Rob, we always love seeing you here. So, you know, it's good that, you know, we do like you turning up. So thank you, and Kevin for turning up. We do like to see you. The question I have for you is that I appreciate your update over the weekend about the provision of that extra unit, testing unit at Outdown. But even though we have a mobile testing unit in Poulton and now 2 in Outdown, residents are telling me that, especially those who live in Poulton, that they are being sent further afield. Now, we've heard horror stories of people being sent hundreds of miles. You may not know this, Rob. It may be for Bruce Lawrence to answer this, but do we know whether the availability of testing for COVID-19 in Bath and North East Somerset is sufficient to meet demand? Are residents having to travel long distances to get a test? And are results coming back in a timely way? And I just wondered, have you got any information about that, or does it need to go to Bruce Lawrence?
Well, I'll give you the little that I know of this, Les, and maybe the context, and Bruce will obviously put more detail in there. I think we're not alone as an authority on experienced issues with the testing regime at the moment, and I too have hear of people going onto their phones or their laptops and trying to find vacancies all over the place. And then that's borne out with the fact that when people go past some of our local testing units, they're not that busy. So there's obviously a problem in the code, in receiving the code. And I don't know how much we as a local authority can actually influence that. Bruce will be able to through his position, and he does belong to many different forums regionally and nationally. So we're quite blessed to actually have him punching on there. But I think until the government actually sort out and I think there's an issue around chemicals as well, because you obviously need to be able to test these samples. And so it's not, I don't think it's so much a local, but it has been added to locally, because now if we've got little ones and they've got a little bit of a sniffle, which it happens every year, you know, they're being told to go and get a COVID test. Travel agents are telling people, go and get a test before we actually sort of fly you anywhere and things like this. And this is all adding to it. And the other thing that I will say is, and it's anecdotal, but I think some people are actually looking to get tests for a peace of mind, not necessarily if they're displaying any of the symptoms, and that actually then adds to the volume that's being needed. So we all have to sort of really show restraint and only go for a test when those signs are there, really.
Okay, thanks, Rob. Lucy.
Yes, I just I think this is a really important point actually that Liz has brought up, and I think we need to come away from this meeting with an answer because it's critical at the moment. I think if people within Baines are being sent afield, further afield at the moment while our own mobile testing units are visibly underemployed, then we need to know whether it's a local or a central problem, this code. I don't think we could go away from this meeting just chatting about it. It's really critical. On a daily basis, people need to, if there is capacity at our mobile testing units, that is where they should be going, and we can't wait a week or 2 weeks to work out where the hitch is, whether it's due to reagents, whether it's due to central labs. This is a different issue, and somebody needs to get in contact and make sure our residents are getting sent to the right place, you know, as a matter of urgency.
Lucy, I think it's a good point to make to Rob, but I think that also it should be made to Dr. Bruce Lawrence, because he would be in a more qualified position to give an answer. I do agree with you. We need to go away from this meeting with an answer from someone. I think Bruce might be the most appropriate person. Are there any more questions for Rob? Don't appear to be. So thanks very much again, Rob. And both you and Kevin accept your reprimands, and we'll see you next time round. Thank you. So if I can move to item 8, and if I can invite Dr. Bryn Bird to update the panel on behalf of Baines, Swindon and Wiltshire Clinical Commissioning Group. Dr. Bird, please, if you could start your presentation. Thank you.
Thank you, Chair. Good morning, everybody. Hopefully you've had a chance to have a look over the report, and we can take questions at the end. So I just, rather than going through it verbatim, I just want to highlight a few key aspects from Health Commission point of view to draw to your attention. They're around the recovery in the system in response to NHSE letter, some outpatient transformation work, and our development into forming an ICS in the BSW area and how that impacts on our relationship with the local authority. So in terms of the recovery work, so there's significant efforts in response to the phase 3 letter to get all parts of the system back up to previous capacities where appropriate. And that counts for some primary care, community services, and elective management and diagnostics. So as highlighted to this panel previously, there are some significant challenges around that in all aspects of the system. And that's principally around management of COVID, social distancing, and infection control. So it's important that we understand that each area of the system has those restraints, and a lot of work is being done in an integrated way to manage those and reduce the inefficiencies that creates. I think looking at the questions that came from this panel last time, there was a lot of understandable concern around cancer services and mental health. So just wanted to assure that that is a key priority in the response to restoration of services, to restore all full cancer pathways, including the 31 and the 62-day pathway, cancer screening, and a lot of work is being done on improving early cancer diagnosis. So that work continues. Alongside that is a priority around getting support for mental health, a recognition that that's been significantly increased by the effects of COVID and lockdown, as well as the challenges that were there prior to that. So there's various work streams taking place and trying to get up to capacity to meet that demand. I think it's important to reflect as well that it's more than just the inhibitions on the system that are reducing some of these sort of cancer pathways and mental health recognition. A lot of it is around patient behaviour and interacting with the system. So we've been quite proactive around that in communication campaigns to get checked out if there's any notable symptoms that you're concerned about, that we are open for business, and also encouraging those with mental health concerns to engage with the system as soon as possible. And that's work we've been directly involved in commission. So I'm happy to take questions on the end around the recovery. I think the second part that's important is some of our outpatient transformation work. So this ties in both to previous work prior to COVID, but also increasingly goes up the agenda in importance in how we're managing patient pathways in our system more effectively with the limits that the hospital, the RUH, is facing. So in terms of some short-term work, a lot of attention has been placed in an integrated way on how we're using technology, including connection to consultants directly into primary and community care, as well as the communications between the two. So how can we get a better understanding of the capacities in elective and diagnostic management, and how can they be mitigated? So myself in primary care, I need to know about the restraints in certain areas so I can communicate with patients. Also, if I think something's more urgent and I know there's going to be a blocker, how can we explore ways around getting that prioritised appropriately? So these are just some of the challenges that we as a system are communicating on and trying to work around solutions to quite complex issues. In terms of longer term outpatient transformation work, we are quite lucky to have a responsive and cohesive GP federation in BEMS, and they are helping to support some training and upskilling in community and primary care of professionals that can help manage that outpatient work. And the focus has been in 6 key specialities that are facing notable strain, well, again, prior to COVID, but has been amplified by that period. So that's something where the work continues, and a recognition that if we maintain that, the benefits to the patients are quite palpable, and that care is sooner in the pathway and closer to home. So I feel that's very important work that we are facilitating as a system. I think the final thing to mention then is developments of our integrated care system across BSW. So the first part of that is about approximately 6 to 8 weeks ago, we had a joint meeting with the local authority and CCG members about where we were in that relationship. So there'd been various changes that had taken place, COVID being one, and the strains that's put on both systems, but also with the merger and the development of our Integrated Care Alliance in BAINS, and trying to understand what that meant to the council and those relationships. So it was an informal and frank discussion, and I think the benefits were understanding where things are going to happen at scale, but also understanding that we as a CCG place high priority on those relationships within BAINS. We see that as a key driver in our longer term priorities of health and well-being, of managing health inequalities and driving up quality within the system. So there's some reaffirmation of that, whilst a recognition that that work continues. I think they are most of the points I'd like to draw out of the report. Just as to note, there's an update on the Think 1111 campaign, the flu vaccination program update, which is especially high priority going into this winter, and something we're very aware of as a system, and also in primary care, and also updates to Bolton minor injuries unit. Okay, let's take questions. Thank you.
Smashing, thanks, Bryn. Jess.
Thank you. And thanks, Dr. Bird. I wanted to ask specifically about the flu vaccination programme, which is detailed in your report, and just really to ask kind of how and where that extended vaccination programme will be delivered, and how would kind of people who've been shielding during COVID, where would they be expected to go for their vaccination?
Okay, certainly. So it's been delivered predominantly in primary care, but with support still from pharmacies and schools where appropriate, as previously. So I think we shielded patients, unless there's a change. There is an understanding as with appropriate infection control measures, they are able to come into surgery, but we should be mindful that social distancing infection control measures need to be at a maximum. We often call them in primary care sort of green zones, where the sort of patients will have been at a high or even moderate risk with any symptoms prior to that, especially of any COVID-related symptoms. We're trying to make those environments as safe as possible, and that includes one-way systems, almost infection control marshals, so making sure everyone's gel in their hands, wearing masks, distance isn't appropriate. So all surgeries, I think, are well informed of that and managing as appropriate. But that's not to say that surgeries as appropriate don't have their system of home visiting as well, or especially to situations such as care homes or housing support areas.
Okay, it struck me in the report that the rollout in November, December for the older people, or not older people, 50 to 64-year-old group could be at a time when we may be in a second wave.
Yeah, so part of that is the prioritisation of the 65 and over and those high risk. But the second part is the availability, the availability of the more suitable vaccine to that age group and when that's going to arrive. It's not completely by design, but it does have some benefits. But it's a multiple factor.
Thank you.
Thank you, Liz.
Hello. Just to say, we in Poulton, and it's not just Poulton, but it's the surrounding area, quite a bit of North East Somerset. We're delighted to see the minor injuries unit has been opened up in Poulton, and it's good to see that. But a couple of things concern me. One is that you say that in your report there was a 75% decline in attendance, and I just wondered over what period of time. You're also saying that it's a telephone triage system, and I was wondering, how is it working, and are you getting many people attending, and do people know that this is actually opened up, that it is open? What kind of publicity has there been? Thank you.
So does that sorry, Liz, does that all relate to Poulton minor injuries?
Yes, yes.
75% figure on my report.
Yes, yeah.
I'm looking at, but not to worry. So there's certainly been communications sent out. I understand that. I think as part of telephone triage, as you can see in other areas of the report, and certainly where we're managing things like diagnostics, X-rays, and non-urgent sort of emergency appointments, non sort of 1 hour or 4 hour wait appointments, that's being used across the system purely as an infection control measure. So that's the importance of that. In terms of that 75% figure, sorry, I haven't got any more information on that. Could you just repeat the concern around that?
Right, but sorry to stop you dead in that. There's always been a concern in our area that some elements of Poulton Hospital may well face closure. Our maternity unit, as you know, the actual postnatal beds and maternity beds have gone. And there's this worry that bits of our hospital in this area will disappear. So when you said there was a 75% decline in attendance, I assumed that was, I know the reason it was closed was because of COVID-19 to cope with the numbers, but is there an overall decline in attendance? Might mean that you're still reviewing its future and what will happen in the long term.
I'm there's certainly no discussions about its long-term viability at this stage that I am aware of. I think a figure like that is high. Of course, it's high. We are seeing that in other sort of aspects of the system that could be considered urgent, and I think a lot of that is partly about communication. There's a lot of impatient behaviour that people have sort of switched off from going to health treatment environments, and that's continuing. And I see it in practice since there's been activity was really rising, but since the talk of the sort of rule at 6, it's dropped off again. You're seeing it constantly. I think it's very patient behaviour based, that is, Liz, whilst appreciating the fact that maybe the communication's not got to everyone that it's back up for business. But say for something like minor injuries, you see people looking to sort of see how it goes rather than attend a setting where there's risks.
Okay.
I mean, to put it into context, I have difficulty getting patients into hospital for things that I know are emergencies. And I can give an example of an MI and also a ruptured abdomen that I've seen where the patient was still reluctant. So where it's minor injury, I'm not surprised if that's down, but it doesn't mean there's a threat or any conversations around that as a threat to the
Good to hear that. Thank you. Thank you.
If I can be vague enough not to identify someone, but I was in conversation with a chap whose wife is a GP, and I said she must be inundated at the moment. And he's saying that she's never been so in the practice where it's been so quiet. And it is a major concern that people are very apprehensive about going to the GP, going to seek any medical help at the moment because of the COVID situation. And I noticed that you have launched a new communications campaign to encourage people to get help early on. And I was just wondering, are you getting any positive response from that?
So whilst I appreciate my previous comments and noting your point there, Vic, I think should put it into context that just start anecdotally and then mention the data. The past 2 months has been the busiest summer sort of I've had in 10 years, and that's true of pretty much all my colleagues. I think there's a lot of strain, one coming out of lockdown, but also if you look at the activity levels, it's been more like an autumn already, and the system's being pushed. Part of that is the inefficiencies I mentioned, but we're now dealing with a situation where we're having to manage all our routine care alongside post-COVID, alongside seeing the acute patients. So it's a significant increase just on paper, and that's being felt. So having said that, I totally appreciate your point, and it's a need to get the balance right then, isn't it? We don't want to not anyone that needs care, of course. So those communications need to go out, and they're going out at a system level. And also I'm aware my practice and many other practices are sending personalised message to patients to get that a better understanding that we are open, but there's still a requirement for triaging. And if we can manage over the telephone, we will do so to avoid that footfall. But anyone that wants to be seen or I feel needs seeing comes in.
Thank you, Bryn. I hasten to add that the case that I was identifying, the doctor concerned is in South Gloucestershire, so it's nothing to do with veins. Are there any more questions for the panel? Yes, Ruth, please.
Hello. Yes, I have a question about the flu vaccination programme. Well, 2 questions really. First, I hadn't actually realised that all primary school children are already offered, and so I'd be interested to know what the take-up is on that. But then following on from that, in addition, this year, children in year 7 will be offered flu vaccinations. And I was just going to ask you, is that a government decision rather than a local one? Because it seems kind of curious to me in a way that children that we're expecting to be in school, and although they may not have such bad symptoms, if they catch COVID-19, they can still pass it on. So I'm just interested about, why cut off at year 7? Why isn't it, through year 8 to 13? Is that a government decision or is it a local one? And please, could you give me a bit more detail about the primary school take up? Thank you.
Certainly. So to answer the second part, that's all central guidance there. So none of that is local. So that's all come nationally, and we're enacting that locally. As to the background of why set the cutoff is 7, some of that would be pragmatic, but there is something about the interaction, isn't there, as an understanding, and getting sort of 11-year-olds to social distance is perhaps a lot more difficult than getting 13 or 14-year-olds to do so and obey some of the guidance. So perhaps that's part of the thinking. In terms of the first part of your question, so that program is carried out in school. The primary care doesn't carry out that program. That takes place in schools.
Okay.
So yeah, so thanks. So do you know, do you know have any data on the uptake? I mean, is it quite well received? Do most children have a flu vaccination?
Yeah, traditionally there's not a problem with it, but it does ask questions of this year of attendance in school. Concern around that, isn't there? Traditionally there's not been a problem, so we'll have to I think see what comes out of this program.
Mark, you're on mute.
Sorry. Referring to the NHS 111 plans, that's managed demand to an extent, but there's been already a number of reported incidents of a large number of ambulances waiting at the RUH emergency department, and that's with very, very low background levels of COVID, and at a time of year when the winter bugs have not arrived. Is there any, are you aware of any plans to increase capacity in the RUH emergency department, or is it simply going to be a matter of things being deteriorating as demand increases over the winter?
Okay, yeah, so urgent capacity has been a long-term issue, hasn't it? Not getting any better this winter, most likely, and just trying to sort of, there's no funding or support to the urgent capacity that it can be quickly met. So I think as a system, we're approaching more innovative ways of managing that urgent care. A little bit about that I alluded to earlier in our use of interactions with consultants, Consultant Connect, amongst other areas. And part of it is upskilling the workforce. Part of it is making sure we're not sending these patients into the front door unnecessarily. Second part of that, which is a work in progress, is getting a community service that can manage these patients that have a high level of medical need, but not having to go into the hospital. So if you like an outreach team, to call it in its basic form, that can deliver more invasive medical care in the community. And that's something we're rapidly working on together with colleagues across the system.
Fine. No more questions? No, it doesn't appear there are. Thank you very much, Bryn. Thank you. So we'll move on now then, if we can, to item 9, and it's the RUH Health Infrastructure Programme 2. If I can invite Simon Cook, Programme Director, and Joss Foster, the Director of Strategy, to present the report, please.
Thank you, Chair. So my name's Joss Foster. I'm the Director of Strategy at the RUH and the Senior Responsible Officer for the HIP2 programme. And my colleague Simon Cook is the Programme Director for the programme, and he's also present. So it's thank you very much for the opportunity to present very briefly today at the very outset of this Health Infrastructure Plan Phase 2 investment in this area. If we go on to the, I'm going to sort of take you through briefly the slides, which I know you've already had, and just sort of like illustrate some key points from them. So in terms of a little background about the Health Infrastructure Plan on the first slide. It's a national strategic funding, and it is Health Infrastructure Plan funding is phased. So there was a Health Infrastructure Plan Phase 1, which was for which in terms of acute hospitals was focused on 6 sites, and then Health Infrastructure Plan Phase 2 The acute hospital phase of that was announced in October last year, focused on 21 sites. So there are other aspects of health instructor plan, but they're own sort of like released in different phases. So if we move on to the next slide, you can see the 21, some of the 21 that are also in the southwest area. So these are the other HIP2, as we call it, health infrastructure plan, HIP2 trusts within the southwest, of which RUH is one of those schemes. The investment is it's mainly meant to be in 5 years' time. Most of the investment will be drawn down, although there may be some limited early drawdown opportunities to support some enabling schemes for this investment. And the national priorities for the investment are fourfold. There's patient flow improvements, standardized design, coordinated and transformational digital improvements, and a greater emphasis on sustainability. So we will obviously be sort of focusing very much on those, but also looking at other aspects that we require for the system. And we'll be working with the regional NHSI improvements and NHS England and other hospitals in the southwest to share best practice. And the money available will be dependent upon a business case, but the allocation is valued at up to £450 million. So if we move on then to the next slide, which is looking at we have a slide which is our approach. So this isn't just about buildings, it's an opportunity to design our estate around our clinical models of care so that they are fit for the future. And it's also going to be of benefit to the wider system. So to do that, we'll be engaging widely, but also at pace. And we will need to submit a strategic outline business case, which is the short list of options for investment, by the end of 2021 at the latest. And there's much to do in that time. So engagement, clinical modelling, options appraisal, etc. So it is, although it sounds like a long time to December 2021, it's actually quite a tight timeline to actually get all of the work done that we need to do. So moving on then to the programme plan timeline. So we have received a small amount of seed funding to establish a core programme team and to do the work necessary to get us through to developing this strategic outline case. So on this diagram, just to explain a little bit, the SOC, which is at the end of the timeline, is the strategic outline case, and the elements in the boxes at the sort of top of the diagram, where it says strategic case development, commercial case development, are all elements of that strategic outline case. We're using the Green Book standard methodology for capital business case development, and those are aspects of a standard strategic outline case. So you'll see that we're doing the system engagement part of the plan now, and then widening that out from January into the sort of the public arena to actually engage more widely. So there's still significant further planning, obviously, to do in each of these areas. So we'll bring it to you at a very early stage of development for your input. Then sort of finally, obviously, we would welcome we've got a sort of brief slide about the next steps, that are the immediate next steps. So this is working with our system partners to develop that clinical model, and then working up the options for the estate solution, and then commencing the outline case development. And we would welcome your suggestions. So we currently plan at a minimum to use a range of forums across BSW to engage. Plus there will be a patient and public engagement process as part of the overall communications and engagement strategy for the programme. So members of the panel will have opportunity to be involved before an update, so vision comes back to the panel at a future date. But we're pleased to come back to update you at any stage as the committee would like.
Thank you very much, Joss. Joss, on your approach, you say the need for pace. We need to submit a strategic outline case by December 2021 and a key to go faster if possible to secure the funding.
Yes.
This suggests that the funding may be at risk, or is it categoric that you've actually won the award going forward?
So there are a number of schemes nationally, and those schemes are all contingent on satisfactory business cases. So, and a lot of the schemes are much more better developed than ours. So I guess there's a window within which that funding is designed to be spent. And if we don't move at the pace that the rest of the cohort are moving, then we risk, I guess, missing out on this opportunity.
Oh dear.
Chair, if I might just amplify on that a bit. So I think we're very fortunate the RUH position in terms of timing, in that the good news is, because we haven't got to develop a scheme at the moment, we haven't got to go back and redesign it, because a lot of post-COVID learning, those trusts that have got more developed schemes are being challenged now by quite a different way of delivering care in the sort of more the virtual environment. But I mean, I've done a lot of business cases for large capital schemes, and it's really important to maintain that momentum. So far, NHSI has been really impressed with the momentum that the trust has generated from very quickly in the last few months. But clearly, it's an uncertain future in terms of government finances. So we want to get there as soon as we can to the table.
So you have to impress with the confidence going forward, so that there's no apprehension at the other end, those that are actually supplying the finance. I've just got your slide on the screen, so I can't see anybody at the moment.
Would you like me to stop sharing, Chair?
Yes, if you could, please.
That's fine. Yeah.
Excellent, thank you. So now I can see the panel members.
Okay.
Any questions from panel members, please? Kevin.
Thank you. I was just wondering how autonomous this project is to the RUH in terms of, does the hospital have to fulfill certain criteria and arrangements that are just specific to the hospital? You said about outpatients flow and things, or is this money and is this plan really destined so that the RUH is a key part of the whole Bath, Swindon, Wiltshire clinical group system, if you like, and it hopefully will add to what the whole system or integrated care system is trying to achieve?
The ambition is certainly for it to be an investment to improve against what or deliver against what the system is trying to achieve. Or generally, there is, I guess, a critical element within the RUH estate to deliver against in terms of our backlog maintenance requirements, and that is a part of the focus of what we need to do as part of those priorities that we need to deliver against.
Liz.
Hi. Firstly, I'm very interested to know why were we selected, the RUH in our area was selected to be one of these major schemes for investment. And I know we've heard, second part, I know we've heard a lot about the business and financial model, but I think a lot of our residents would be very interested in finding out how far has your thinking gone about potential priorities that the RUH would be pursuing?
So in terms of why we were prioritised, very exciting to to have been so, is that our understanding is that the 21 hospital sites were prioritised on the basis of the opportunity to significantly reduce backlog maintenance, and backlog maintenance reduction of that has been a significant feature of the IUH estate strategy over past years, most notably focused on the buildings of the Second World War era on the northern part of the site at Coombe Park. But at our last review, despite having done all of that work, there's still a significant investment required across the remainder of the estate. So that's our understanding of how we have come to be prioritised in terms of that list. And in terms of the, we're still at the stage of actually engaging with partners and the system in terms of setting out our priorities for what we'd like to achieve in this programme. So we've obviously got those national priorities, but so the next phase is this engagement with colleagues to actually understand how can we best deliver against what the system needs, as well as obviously the necessities of sorting out backlog maintenance as well.
Andy.
Hello, thank you for coming. It's very encouraging that we have such that we've been one of the chosen places to have the benefit of this funding. I'm aware that the Circle Hospital in Peasdown is for sale. Is there any chance that that might become part of the RUH, or sort of a partner within the RUH in some way?
I couldn't say, to be honest. Obviously, we are going to be looking at all of our clinical models and understanding what capacity we need for the future, and we'll be looking at all of the options around how we fulfil that. But we're at too early a stage yet to say anything on that front, really.
Mark.
Yes, thank you. You mentioned a figure of 450 million. Is that to be divided by all 21 schemes, or is that specifically for the South West region?
Sorry, I couldn't quite hear. It was a bit muffled, sorry.
Sorry. You mentioned a figure in your presentation of 450 million.
Yes.
Is that to be divided between all 21 schemes, or specifically for the South West region?
No, that's a specific number that's been allocated to the Bath scheme.
Oh, the Bath scheme.
Yes,
Right,
each scheme has a different allocation.
Okay, fine.
Anybody else? I mean, it's a huge, it's a drop in sum of money, 450 million, and for it to be selected for our hospital, I think that's marvellous. What, as a panel, we would like to do is have periodic updates from Joss, because this is such a huge project, and we would dearly like to make contributions to how it develops to reach fruition. So can you advise us on how often would be an appropriate time for us, for you to come to the panel? What's realistic, bearing in mind it's a very tight time scale, and I don't mind if you come to every panel meeting to watch this grow to good effect. But when do you think that you'd have something that the panel could respond to next?
Well, I'm just wondering, because your next meeting is in November, isn't it? So, and that seems quite timely in terms of the early stage of engagement work that we've been doing, and we can report back on that, and then we can discuss with you what our plans might be for the next phase of public engagement, which will be into the new year. That would seem to me to be a good first step, and then we can also outline the kind of key milestones from there and what you might want to see at what intervals they're on. Yeah,
that sounds excellent. Then we can each meeting was there, we can adjust to when would be the next appropriate time for you to come. But if we can now give you an open invitation to come at the November meeting and give us the next update, I can see by nodding heads that meets with the will of the panel. So we look forward to seeing you next time, and and well done to what you've done to date for your team there to win that. You've obviously given a very convincing presentation to whoever, but well done. So thank you very much.
Thank you.
We'll move on then. Is Bruce present now?
I am, Vic. Good morning. I've just joined.
Bruce.
That was very good timing.
Excellent timing. So Bruce, can I hand over to you to address the panel, please?
Okay, so I think what you want me to do is just give a brief overview of COVID. I mean, there are a few other comments I could make about public health, but mostly public health. Other services are working reasonably well, adapting to COVID, and now trying to adapt to the post lockdown. And I probably don't have a huge amount to say, you know, all the children's and the drug services and the sexual health services, they're kind of, you know, versions of okay. They've had to make quite significant adaptations, and providers have made really, really big efforts to keep services to vulnerable people. So on COVID, shall I just give a very brief sort of overview of where we are with the pandemic and what we're doing, and then probably take questions rather than give a long discussion?
Yes, if you give an overview and the questions will
so
debate.
Where we are is in absolute terms, case numbers are rising. You all know that. They are in Baines as elsewhere. Baines is still, I think we're now the 6th lowest in the country overall. And what we're seeing is that we've had one, you know, I say small-ish outbreak in the Summer Valley area that we have managed to control, that was based around a pub and a social group mostly. We've had scattered cases in a few care homes, and I think one, possibly 2 schools, just single cases. And then we've had just scattered cases, which is much what's happening elsewhere. We're about average for the Southwest now. The Southwest is maintaining its position at the lower end, but more generally regionally, there have been significant outbreak in Swindon in the Goan community, and Bristol more generally. So we're facing a possible second increase, and we will certainly see an increase through the autumn and winter. We're also facing risks of social opening up, schools, universities. A lot of work has gone into all of those to try to do them as safely as possible. But every single thing you do that brings people together potentially creates risk. And now you all know that the rule of 6 was brought in because I think, to be frank, the increase in cases throughout the country were quicker and more than had been suspected. I think an increase through the winter everyone knew was going to happen, and perhaps a very big one. I think there are 2 ways to look at this. We'll have cases and then we'll have illness and death. And so far we've had an increase in cases without very much increase in serious illness and death. The increase in cases has been largely or much more in the 20s, the biggest age group, then 30s, then teens, and then older people have been affected, but much less so. The worry is, at what point will that spread through the generations? And the, you know, true answer to all questions about COVID is we're not really sure, but we need to prepare. And I think what we're doing is being very cautious around care homes. So, for example, when we had that outbreak in the Summer Valley, we chose, the COVID board, to shut the care homes, even though there was no obvious link and no obvious immediate risk. It felt precautionary, it felt the right thing to do given what had happened to care homes in the past, and we've now been able to open them up, but we will continue to be cautious. Our role in the council is, I always try and say first and most is prevention, asking by whatever means, and you know, enforcing where we can't, ask people to behave in ways that will not spread the virus. And that's all the social distancing that you all know about, and the washing of hands and the wearing of face masks, because really if we don't control outbreak, if we don't control spread, we're going to lose it. Then after that, you get cases. We work very closely with Public Health England. We investigate cases. We particularly look at where there are links that might lead to a suspicion that we're going to have, you know, more of an outbreak than just a single case or a couple of cases. There's the track and trace, the testing system, not telling you anything you don't know. It's under huge pressure. The demands are greater than the ability of the system to gear up. And that's leading to terrible frustrations, terrible problems. You all have been contacted, you councillors, by people saying, why can't I get a test? And the answer is because all over the country and locally, just the demand is bigger. Some of that comes from people asking for tests who shouldn't, who haven't got symptoms, or a workplace says, I want you to have a test to come to work, or someone wants to go to some sporting event. That shouldn't be happening, but it is a bit. But I think even were that not happening and were only symptomatic people and only key workers, we'd still struggle. This is all over the country. The government, I think to some extent, is concentrating test capacity where there are the most cases, which in one sense sounds reasonable, in another sense, you know, it's probably arguable, but that's what's happening. Supply is increasing. The tracing system, likewise, it's a difficult thing actually, and it's a lot of people have been recruited to do tracing quickly and trained quickly, but it's a difficult thing to do, particularly in communities that, you know, particular cultural communities. We've had very, very good support from PHE, so I'd say our tracing has been good. And case in point, we did control the Summer Valley outbreak. But we're bracing ourselves for more to come. So there's testing, tracing, treatments are better. So far, the NHS has not seen the brunt of it, but what you need to be aware of is the NHS is very, very busy again. You know, at the beginning of the first wave, everyone was moved out. That's partly what caused the problems in the nursing homes. All elective stuff was stopped. Now there's a kind of catch up, and the NHS and the Royal and Salisbury, all the hospitals and BSW are really running quite full. So we don't have a lot of capacity, but they're not seeing a lot of COVID related illness yet, but they'll start to see some. And then there's the vaccine and the flu vaccine separately. We don't know when the new vaccine will be available, but most people are kind of saying it'll be mid next year at best. I don't expect it to be quicker than that, really. Flu vaccine is really important. Flu is really important for two reasons. One, we don't want people to be ill with flu, so we're trying to beef up the vaccination. Secondly, the confusion. We won't be able to tell if someone has a fever from flu, whether it's flu or COVID, just can't be done. So we'll have to assume it's COVID and for isolation, but that's very disruptive. And to some extent, the pressures on the testing system will make that worse, because if you had a sort of fevery flu, you could get a test and show actually it's not COVID. That would be helpful. So winter, we're really bracing ourselves for a lot of pressure. Schools so far have gone back. They seem to be doing okay. Nursing homes are fragile. We've had a couple of cases. So far, the nursing home system, the care home system is holding, but that's fragile in the winter. And of course, that can knock onto the NHS. Universities, a lot of planning. I think that's probably enough to throw at you for a sort of opening pitch. If you have questions or comments and I can answer them, then please do. If there's something else you want me to talk about that I haven't covered, because I can't tell you everything in 2 minutes. Thank you, Vic.
Thanks, Bruce. It's a good point you make about the flu jabs. And it was only announced this morning that 132 out of the 149 areas in the country have either experienced an increase or they've remained constant. 17 have fallen since September. But in the 17 is Swindon, for example. Well, Swindon had a big hike. So, if you're having a hike, then a fall's more apparent. But so we've been consistently low, and as you say, we're the 6th lowest overall nationally. And I think that that's a credit to everybody that's worked and been involved in it. But I've got Liz now that would like to ask questions. Liz?
Yeah, thank you very much, Dr. Bruce Lawrence. Bruce, for coming. I must admit, I do really feel very safe with you in charge, because I think you've really got a handle on what's happening within Baines. But I'd just like to push a little bit further and just find out a little bit more about what you said. We now have 3 mobile testing units, and I'm just wondering, are we now having sufficient? Have we now got sufficient in Baines to meet demand? because anecdotally we're hearing, as you said, we would, that people are being sent out of the area for tests, and our results coming back in a timely way. And my third question is, do we need more resources? I mean, have we got enough resources at the moment? You're probably going to say no, but anyhow, do we have enough resources? So really, what about demand, the supply meeting demand when it comes to testing, as we've got 3 mobile units now? And
Right.
but do we know, are people traveling long distances for a test?
Okay, so I'll say a little bit more about the testing. The answer to any question on enough is no. We have now at the moment, now Becky's my expert, but at the moment I think Odd Down is working, Poulton is, but we're going to reduce it now that the cases in that area have gone, and only stand it up if we have more cases there, because we're using the goodwill of the football club and we don't want to outstay that. And then we're opening up a town centre walk-in for people from Bath just to be able to use. And then remember there's the home testing, and then remember there's the nursing home testing portal. The problem of having lots of places is the number of tests is capped in general. So if we had more, it would dilute. So even the centres we have don't get all the tests that they could theoretically use, and that's a national issue. So having more in a way isn't having more, it's just sort of spreading it out. And we think concentrating is still probably the best thing. People are being asked to go far because there aren't enough tests, and the algorithm that was used first basically looked around everything. So it sounded crazy to be sent to Inverness, but if that was the place that had a test, that was what the machine said. Computer says yes. Now it's being capped at 75 miles, so it's not quite so crazy. But people can get home tests too. Turnaround times are also a problem. Yes, the labs are short-staffed. They're looking for rapid recruitment and opening up different labs. So, and that's a problem too, because of course, if the turnaround time is long, it creates inconvenience to everyone and to key workers and to contacts. And I think some things are getting better. So I had a talk with the minister, not me, 300 of us had a talk with a minister last night about the care home issue. And she says now that they are protecting that, and that care homes should be able to get what they need. And actually more of them should be asking. Also, I've had talk with PHE, and PHE locally says, look, if you really need a wad of tests in a care home or some very particular situation, they also have some, and schools all have a little starter kit too. I don't think universities do. And in terms of resources, I'm always trying, we can't get more tests ourselves. I'm always trying to use the national test and trace and the PHE the best, because for us to significantly up our resource to really start to take on contact tracing, it's a very big injection of new staff, money, and I've heard about places that have done it, and it's I'm not sure about the cost benefit given where Baines is. Of course, right around the system, everyone could use more resource. One thing I didn't mention was the app. The app is being trialled in a few places. Newham, for example, interestingly, it's not going to be the answer to all problems. It's just going to be another bit of a picture, and it requires quite a lot of rolling out to it, requires quite a lot of work. It's not just a matter of telling people, this is the app and use it. You've got to really get people to understand what it's about and to trust it. A lot of people don't trust it. They don't trust that data won't go to a place they don't want it to go. So that's the best I can answer you, Liz. It's an ever-changing situation.
Okay, thank you.
Thanks, Kevin.
Thank you. Just trying to understand, Dr. Lawrence, how much autonomy do you have as if you like, the local sort of person responsible for the COVID management, or are you very much reliant on everything that has to come from central government?
Mostly the latter. I mean, the basic testing and tracing capacity is central and regional. I have a very small extra capacity for example, people to go and do training in nursing homes, to the EHOs can go and look at local businesses in coordination with Public Health England. In extremes, in particular situations, we might even be able to take on a little contact tracing, but we're trying not to take on that because it's you know, we don't have enough. The autonomy I have is working with Public Health England to prioritise in my area where, you know, between me and them, we say, well, where do we need their most focus? Potentially autonomy around deciding where I think things should be, you know, venues or events are shouldn't be supported or not doing the right thing. That needs testing. The coronavirus powers need testing, but that's sort of another area. Probably, you know, the true answer is I have to work within the system, and then within that system I can move it a bit, I can manage it a bit, and I can put a little bit of little bit of a council resource in, or even NHS if I talk with the NHS. That would be realistic. I think as testing gets much more, there will be perhaps more local. You know, we were told there would be local control of testing. And possibly as the tracing system matures, there might be some more of that I can direct. But at the moment, everything is kind of catching up. So that's and of course the powerful role that I and you and Dina and everyone have of speaking to our communities as trusted voices. You know, I'd say that's another really important thing. I've done a reasonable amount of media work, not loads, but we're having a comms. You know, the comms team are working hard, and we're getting a new comms officer, especially to focus on COVID, to try and get the message, particularly to younger people who, you know, aren't necessarily hearing, and it's difficult to influence. That's my answer, Kevin.
Thank you. Any more questions for Bruce? Yes, Andy, please.
Thank you. My question is about the apparent contradiction between the increase in infection but the not significant increase in the deaths. So what are the reasons for that? Is it COVID-19 is mutated, or is it because there are younger people getting it and so the older people who are more vulnerable are not? Or is it that the treatment we offer now, I know we haven't got a cure, have we got better treatment? So, or a combination of all three? I'm just interested to know why there seems to be a contradiction between deaths and the rise of infection.
So an uncertain combination of all of the above. I think some very clear bits of that are currently the main, the largest number of cases are in 20 to 30, and then the next largest 30 to 40, and the next teens, and then relatively fewer in older people. And I think that's because younger people are mixing more, perhaps because they're less careful, but perhaps because they're the big frontline workforce age and living close, you know, there may be some often poorer and live, you know, closer together. Older people can space. And I think older people have become more risk averse. So there may be shielding, self-shielding to some extent. I don't know if some of you have changed your behavior. I'm much younger than most of you, but even I have. I think treatments are getting better. When we start to see more people in hospitals, we'll see that even of the severer illness, there'll be less. We are wondering about whether the virus is changing behavior. I have heard nothing but kind of rumors that maybe it's getting less dangerous. Maybe it's getting more transmissible, but less dangerous per case. I think the big question that we can't answer completely is if it is largely in younger people, will it inevitably move to older age groups, and will it do that to the same degree? And I think one other last thing about what you're saying is that in the beginning of this whole thing, the saving the NHS capacity was overruled everything else, and so people were moved into care homes where they shouldn't have, where it was too early, and they seeded infection. So we're not going to make, I think that's one mistake we won't make again. I'm not saying we won't get cases in care homes, because of course staff travel, and you know, inevitably you will. There are a lot of people in them, and many who get it will die in care homes because they're the most oldest and vulnerable group to a large extent. But I don't think we'll have that mass seeding. So I think it's a bit of all of those is why we're not seeing it yet, and whether we will see it and how it will materialize is really like just one of the biggest questions. And in different countries, we're seeing different levels of that playing out. In some, you know, some like in Marseille, they're getting bloody tight in their intensive hospitals, but other areas we don't seem to be seeing that rise. So that's the best I can give. There's a lot of uncertainty. It's a new disease. We still haven't had it for even 1 year. Ruth.
I think Michelle wanted us. She was before me.
Okay, Michelle.
Just a question, Bruce. Thank you for your update. Question on the number of tests locally. You mentioned that they were capped. So regardless of how many sites we have, we still got the same number of tests locally. And I was just wondering sort of how many we have compared to the number of people that are turning up at testing sites for testing, i.e. have we got enough locally?
Well, nowhere's got enough locally. We are now, there was generally, when there was generally enough, people weren't really supposed to turn up, but if they did, they get taken. Now they won't. There's a much stronger steer that you mustn't come if you haven't got symptoms. You mustn't ask for a test and you can't turn up. It varies day to day, and it varies place to place. You know, if Becky was here, she could probably give you a better idea. So I can't say with authority exactly how many each day in each location. It may be as little as half. It may even be less sometimes. So no, we've not got enough, and that leads to the question: well, if you think you might have COVID, what do we say to people who can't get a test? And what I'm saying is, if you've got one of those 3 symptoms, you have to assume you have COVID. You have to self-isolate. Your household has to self-isolate, and in fact, once you're like that, once you can't get a test for a few days, then you might have become negative. So then you're just going to have to live with it, and that's really unsatisfactory. And the government is getting, you know, kicking from all directions about it, and I would say working very hard, but it's not something they can gear up as quickly as necessary. I mean, we can have a big discussion about that. So, and I think the priority in where they go will vary, but I have to say Swindon has been our big hotspot in the southwest, and my counterpart there was, well, he's bald, but if he wasn't bald, he would have been tearing his hair out at the difficulties he had in getting enough tests, even where they had a really big local outbreak. So, you know, probably you'll find no one is entirely happy with this at the moment, and least of all the public, and I'm sure not yourselves.
Can I just ask a quick supplementary question, please? Just about, you know, how big is the area covered by the cap? Is it just for Baines, or is it?
No, it's the whole country. The whole country every day is in a game, silly word, but I mean a game of where do we need most, where can we get most, where do we have capacity, where do we have outbreaks. None of this is about Baines. All of this is about everywhere, and we're just lucky. And I'm so, you know, it's so kind of you, Vic, to say something of this is to do with myself, and you know, maybe 1% of it is, but probably most of the position of Baines compared to anywhere else just reflects demographics, age, wealth, ethnicity, numbers of people who can work from home. I mean, I'm hoping we're doing our best, and my team is working incredibly hard. And also we're answering 5 days a week. We're answering public questions on a rota, so we are doing a lot of good work. But really, you know, a lot of this is slightly predetermined. And one of the things that Baines will start to put our cases up. Although I completely support universities starting, I'm absolutely not saying against it, but inevitably, you know, that will be a place where we'll start to get cases. Hopefully not illness, severe illness and death, but you know, we have to expect that, having a lot of people coming in. A lot of planning has been done, you know, really good planning, but you know, I'm just telling you to expect, you know, our position might slightly shift as we find that plays out compared to others, but hopefully we'll still be at the low end.
Right, Ruth, your turn.
Thank you. So yes, thank you for your update. My question is about the tracing, and I just wondered what can you do to make sure that restaurants, pubs, and so on are complying and actually remembering to take contact details of their guests? Is there some So can you tell us a bit more about that? Because I'm thinking, especially with more students, the population increasing and the students, how's that work? Thank you.
It's a discussion between us and particularly our environmental health team and restaurants. We tell them that they need to keep the rules. Our environmental health team go on what they tell me are business trips. I tell them they're pub crawls to see if, you know, this is happening. If there's a case in a pub, we really look at it hard, and PHE will look at it hard. If we really think a place isn't complying and there's real risk, you know, we potentially have powers. And I had a discussion with someone from the Joint Biosecurity Unit and the other regional directors last week, who was saying, you know, if you really think you have risk, use these powers. You know, it's quite a lot more I could say about that, but we have a bit of a stick. You know, you all know that you need to mostly do all these things. There are many venues, there are many people. You have to mostly do these things by partnership and persuasion, but we've got a bit of a stick. The tracing system as a whole, it seems, in what I'm seeing, it's quite hard to fully understand, because there are different tracing. How many contacts do you get? What happens to the contacts? You know, there's a lot of complexity, but it seems to be working reasonably well. The Public Health England bit, when something seems to be higher risk and it goes to Public Health England, the tracing is incredibly thorough. You know, these are people who've done this all their lives. When it's sitting with the regular system, it's not always so thorough. But I think in Baines, it seems to be reasonable. You know, it changes all the time. Of course, the one thing we have very little control over is, what do people do if you're traced and you're told you're a contact? You know, can't put a policeman on you 24/7, can we? Basically, we have to rely on people doing the right thing. And I'm hearing evidence that nationwide, that's not necessarily happening. And we certainly know many examples of people who haven't quarantined, and worst of all, have got off a plane and gone on, you know, to 5 pubs. And some of the outbreaks, like in Bolton, you know, seem to be something to do with that. So I think behaviour is like a bell curve, isn't it? You know, some people are brilliantly compliant, some don't give a damn, and then in the middle, you know, imagine it for yourselves and your friends. You'll all have seen a range of compliance issues. So we do try to make it work, though, and they do have a responsibility. And I believe it. I'm not sure if it's a legal duty, but it's certainly, you know, binding guidance to take contacts. So that's how it's gone, and it's variable. You know, we find a lot of venues that are very good, and we found some where we get complaints and we have to look at.
If there is an abuse, then the stick should be used, I believe, because the costs are so profound. If it's not, and if you don't use the stick now and again, then this has no substance. So
yeah, I think you're right, Vic. I think you're right, and I think I have a different view to things like the schools and universities, which feel extremely important. You know, I think things that are social, do them, keep them open if we can, but there's no excuse for not doing it in the right way and the best way, is there? When it's just about going.
It ruins it for everyone else. Yeah, Kevin.
Yeah, thank you. Just one final comment, really. I'm representing a lot of local school leaders, Dr. Lawrence. Are we correct, or am I correct now in sort of understanding that the only way to, or the person to lobby for getting the testing situation corrected is central government?
More or less. You can kick me and I'll kick them, but I mean, to be honest, 40 million people a day are screaming at them. So I think they do have the message. They're being incredibly performance managed, which is partly why you get quite a lot of spin coming out. You know, we're doing this, we're doing that. You know, they are on notice. So yes, you can lobby. I would be really happy if you would, but I'm not sure it's needed. Perhaps pointing to specific issues, that rather than just saying there's not enough testing, which is, you know, loud and clear. If you have very specific issues around schools, that might be more useful in a way, and you either tell through your own Matt or whatever route, or you tell me, or you tell Claire, who's my school liaison, and we will say, but remember, you know, there are many of you in the country, and I suppose, you know, most of these have been identified. I think the problem with schools for me I think you're all doing, you know, really grand job, will probably come when you start to get lots of sort of sniffles and fevers and this and that, and you won't be able to know easily what to do and how to differentiate. And I think that there'll be problems from that. So I suppose keeping those bubbles tight, keeping the distancing good, so even if someone does have something, you know, you can limit the damage of that is probably, you know, the salvation that is there, if there is any.
Any more questions for Bruce? No, I don't see anybody showing. So Bruce, we haven't seen you for a while, so you've certainly made up for it now.
To chat to you, nice, and I wish you all luck. It will be a bumpy ride this winter, I'm afraid, whatever we do. Good luck.
Well, thank you very much for your contribution, Bruce. It's much appreciated.
Thanks, Hitch. I'll go now, yeah?
Yes,
okay?
thank you. Thank
Lovely.
you. Panel members, would you like a break? And see a few friends out. So if we have a very short break, we come back at 11:50. So we've got 4 minutes. Okay.
Thank you, Chair.
Yeah.
It's nice to stuff.
Right. Only that much left to do. Right. Have we got a full complement?
You have enough to carry on, Chair.
Right, okay. So if we can move on to item 11 then. Right, item 11, it's sorry, crikey, it's item 8. Yes, it is, yes. Right, I'm getting back to it now. Virgin Care Independent Commissioner's Performance Report, and it's a 6 months update. And if I can invite Les Hutchinson and Claire Thorogood to present the report, please.
Hi, sorry. Hi, my name is Leslie Hutchinson. As you know, I'm the Director for Adult Social Care Complex and Specialist Commissioning. And my co-presenter today is Claire Thorogood, who's also on this Zoom call. Claire, if you'd like to introduce yourself.
Good morning, panel. My name is Claire Thorogood. I'm the Head of Contracting and Performance, and I lead the contracting arrangements for the Virgin Care contract.
We also have, I believe on the call, we've got Kirsty Matthews, as you've just referred to earlier on, the Managing Director for Virgin Care, who, if needed, will be able to help and support us in any answers that we might not be able to give to the panel today. So by way of introduction to the report, this is a Commissioner 6-month update. It follows on from the report that we gave in March to the panel. And what we've tried to do is concentrate on, we've given an update generally in terms of what we believe is important and the panel would want to know, but we have done a particular focus for the panel on delayed transfers of care, which was something that came up quite significantly at the last meeting, and also in terms of recruitment and retention of Virgin staff, and there was particular mention of the staff appraisal system. So you'll see that in the report there's quite a lot of detail within that. We've also done an update by way of how Virgin Care have responded in terms of the COVID period and how they continue to do so. And I think it's important for the panel to notice when they look at some of that performance indicators, that a lot of that activity might be changed slightly because of what we've had to employ due to social distancing measures, and moreover because some of those measures aren't being collected because the guidance that came out from the government ceased some of those normal measures we were looking at to even happen. I'll go on to more detail in the report as we go through, but if I take us to the main body of the report now, you'll see that what you've got is the main report itself, and then you've got some supporting documentation around the actual performance indicators. And we've put the narrative explanation to those performance indicators, both in the appendix, but also within the content of the report itself, to try and give greater explanation to some of that. Claire and I are doing a joint presentation on this, and Claire's going to then lead us on to the next bits of this report to give an update, and then I'll come in as and when Claire and I have agreed. Okay, Claire, do you want to go?
Thank you, Les. So by way of contract up-to-date panel, just to update that we're now, as of April this year, we're in year 4 of the Virgin Care contract. That's a 7-year term with the option to extend for a 3-year period. And I want to draw the panel's attention to an option appraisal project scope has now been developed and drawn, and that will allow us to take a decision on how we progress with that in the coming months. With regards to the actual contracting each year, that goes through an annual cycle. Due to the COVID-19 pressures, we've had to adopt a slightly different approach this year, as I'm sure you will understand. And what that has allowed us to do is concentrate on the finance and the contracting schedules to be issued early part as a priority. And then the aim is later on, by the sort of end of October time, the remaining schedules that make up the annual contract will therefore follow. In terms of governance arrangements in the Virgin Care contract, of course, in line with the requirements to actually ease the burden and allow our prime providers and providers to concentrate on our public health emergency that we've been experiencing due to the COVID-19 pandemic, we did take a decision to suspend at the early part of the contract year, and that was only in April and May, some of the governance contracting meetings with Virgin Care. And what I've done below is outline in the table those governance meetings that did not happen and did not take place. However, I would like to draw panel's assurance to the fact that for the statutory function of adult social care, the service level performance meeting for that function continued on a monthly basis. And as of June of this year, we did then reinstate what we refer to as CQPM, the Contract Quality Performance Meeting, FIG, the Finance and Information Group, and the Quality Subgroup. So we went back to undertaking, if you like, our business as usual governance meetings. And as I'm sure you'd appreciate, a large proportion of those meetings actually detailed how Virgin was supporting as a provider and the changes to services and the impact of COVID on their service delivery. What we also then did is reinstated, as and when appropriate, in line with the governance structure, the other service level performance meetings. I would also like to make sure that we give recognition that at the early part of the outbreak and the lockdown, commissioners had daily calls, albeit virtually, and update calls with service leads and commissioners to make sure, you know, there was the oversight of the safe delivery of services or changes to services that needed to happen. In terms of the contracting, there are actually 5 service specifications, but even those are now towards the end of the negotiation at final stages of approval. Those will be going into the Virgin Care contract at the end of the October period, when the remaining schedules are completed and sent to Virgin Care for signatory and approval. I would also like to draw panel's attention to the fact that we've had now 2 council-led audits undertaken of Virgin Care and the contractual relationships there. The first one was in relation directly to our governance and contracting management activity as a joint commissioner, and that had an outcome of level 3 for reasonable assurance. And the other audit was regards to the project management for the ICR project governance, and that had an audit outcome of level 2, and that is referred to as limited assurance. I have inherited all actions in my role, rightly so, as the lead contract manager for the Virgin Care contract, representing both the CCG and the council. And we have agreed through ratification a detailed action plan. Oh, I've just lost my screen, apologies. A detailed action plan that I will be leading on those actions, the first of which will be completed at the end of October in line with our next governance meeting. I'm now going to hand over to Les, who will lead you through the next section.
Thank you, Claire. So forgive me for not looking directly at the screen. I'm trying to read the report at the same time on a different screen, so my head might be slightly tilted, but I am concentrating on looking at the report in detail. So just coming through the bit now, we're on item 4 of the report, which is looking at Virgin Care's role and responsibility and responses during the COVID period. And Virgin Care, like all providers, actually did a very prompt response. And I have to say at this point that they fully engaged with the daily hub calls that Corinne Edwards was coordinating tirelessly, actually, to get us through that initial period, and has continued to do so on a weekly basis throughout this latter period. And Corinne has been very clear with all providers, not just Virgin, but also commissioners and providers, that they may need to step up and come back into full force in the way they were before, if our figures, outbreak figures, change, and if our system flows need to be looked at in more detail again. But they do continue, and Virgin continue to be a very active player in that. What we've set out in this report is the things, this first part of this is the bits that Virgin did in response, generic response to all of their services. So as you'd expect, they all their business continuity plans were updated in line with COVID, and they did a critical service list update and prioritised the services as we would expect to see, making sure that they complied with social distancing and making sure that they were responding effectively. And what they also did during this period, for those services that weren't able to operate in the way that they had been usually doing through their routine work, such as learning disability day services, for example, they redeployed those staff to those critical service areas, such as reablement, which we'll come on to later, because that's one of the reasons for the delayed transfer of care figures being as they are. So they very successfully redeployed 200 colleagues to those critical services and made best use of the staff that they'd got. And all providers did that, actually, but they were very successful in doing that during the period. And we welcomed that approach, actually, as council and CCG commissioners. In addition to that, they responded very quickly with the new discharge to assess guidance that came out. And then that changed again at the end of August now. And We only got the guidance on the 21st of August for the new way the discharge to assess model was going to be implemented, and that had to come into first on the 1st of September. And again, they worked really hard to make sure that that was in place and ready to go. So as an organisation, I think it's fair to say that they've responded very ably and swiftly and flexibly to meet the demands, and they were a real system player in that COVID response along with other partners. As you'll know, and as Councillor Appleyard alluded to earlier, along with the Council and the Clinical Commissioning Group and third sector groups and the 3SG group, they responded swiftly to setting up the Compassionate Communities Hub, which was actually a great success in terms of responding to people that we wouldn't ordinarily support through adult social care and health in the same way that we needed to during this period. And it's to their credit they were able to take that role. In terms of adult social care, what I've done under 4.2 is listed the things that they have done. So they had to look at each service user that they support or have character assessments for and review and do a risk-based approach. And for adults with learning disabilities and autism, you will see that they conducted weekly checks, welfare checks for people and services. And for those people that needed to go to day services and they were not able to deliver those in the same way, they came up with a whole range of creative ways in which to keep people safe and ensure that they were supported during the period. And they had to think about, for people that were staying at home more frequently, was there a risk of carer breakdown? How were we going to support that? Did we need to even open up the day services, but in a managed way for a small cohort of people that might still need to do those? And they were flexible in their arrangements with all of that. They supported people with direct payments, and a small team gathered together to contact the individuals. I'll come on later to work I'm doing with the Disabled and Direct Payment Service User Group, but I think there is still some work to be done around the support that's given to direct payment service users, but I'm confident that we can work with Virgin colleagues to do that and get the balance right between what the service user themselves would like and the type of support that was offered. And I mean that in a positive way. And then you will see that they maintained the safeguarding arrangements, and in fact they outshone themselves really in terms of making sure that there was 100% of all the decisions were made within the expected timescales. And I think that was because people were very conscious of things coming into safeguarding and making sure that they were responded to quickly, because we didn't necessarily have all the usual eyes and ears on people that we would have during this period. So they did very well in terms of that. In terms of health services, they responded very well in terms of setting up a community swabbing team in the first instance, and they did a lot of work in terms of PPE and supporting mutual aid, and they did embrace new ways of working to make sure that some virtual consultations took place. Now, with continuing healthcare assessments, and that's one of the things where the performance looks less good, it needs to be acknowledged that when the new guidance came out in March, that stopped any new continuing healthcare assessments taking place. So that has had an impact on that, as you'd expect, and that's no different to elsewhere across the country. And they developed community hospitals to make sure that they had safe distancing, as you'd expect, to make sure that we could support people in the hospitals. Similarly, as you'll remember, Virgin Care run children's health services, and I think it's important to acknowledge that they continued to deliver the children's health services to the best of their ability to do that, embracing new ways of working, as you'd expect, and making sure that the special educational needs health assessments took place as required. Those which were needed to be face-to-face, they did take place in a face-to-face way. And I will just move on to the section 4.5 for Compassionate Communities Hub, where Claire will do a very, very brief bit on that.
Thank you, Les. It's to pick up again on the kind introduction from Councillor Appleyard at the start of Scrutiny this morning, where you know, we had an update on some of the key activity that's been delivered by the Compassionate Community Hub. But I think it's fair to say that that's been received as a resounding success. of a piece of innovative integrated service delivery from, you know, operationally being led by Virgin Care, supported by the CCG, the council, 3SG and 3SG members, and engaging, you know, several thousand volunteers to offer support to some of the most vulnerable and the most needy during this pandemic and in crisis activity. I have to say, on a personal level, it's been an absolute pleasure to support this in the role that I undertake on behalf of the CCG and the council, to work firsthand with these organisations to deliver this service.
Okay, if I come back and move us to talk about performance then. What we've done in the report is set out performance, activity and performance for the end of the financial year 2019-20, and then we've looked at performance for 2021. So it's set out in two sections. We reported in the last report that we did very well in terms of our adult social care outcome frameworks return, and in the majority of those measures, key performance indicators, we were doing extremely well and were either better or above the national average, and in some we were in the first quartile. You will recall from the last report that there were 3 areas that we remained in the lower area on, that were an area of concern for us, and they remained the same throughout 2019-20. That being, if you look on the top of page 7, that there was the outcome measure in terms of short and long-term needs being met, and in terms of admission to residential and nursing care, those figures remained at a place that we didn't want them to be. You'll see since the COVID period, we look to have improved on that performance. However, it does need to be noted that with the new discharge to assess process coming into place, people are still being placed in residential and nursing care, but those people being placed in nursing, or those coming out on the discharge to assess process, might be showing in health figures rather than in social care ones. So I don't want to give any illusion that people still aren't being placed. The priority is always to get people home first and to try and keep people in their own home, but we have got a higher rate than we would like to see. And part of our strategic plan going forward is to think about how we are going to change that. It's not to say, please note, that it's not to say that we are unnecessarily asking people or supporting people to go into residential and nursing care home setting. That is not the case. We are doing quite a big piece of work with Virgin Care colleagues at the moment, looking and making sure that all of those placements, as they are, rather than packages which are for somebody in their own home, but all of those placements are appropriate. And I'm confident actually that through this year that figure will change. People in receipt of direct payments, the situation is the same there. You'll see that there is a slight decrease, but you'll know that we did quite a big cleanse previously in 2018. And as I say, I'm working with a group now of disabled service users, albeit a small group, but I'm hoping that through the co-producing work that we can do together, we're going to be able to start looking at some of that and making some recommendations to Virgin about how things can change. The delayed transfer of care figure, particularly Councillor Hardman had raised that previously about wanting to look in more detail, and you'll see that in Q4, you'll see that from figure 1, that from February 20, which is the last figure that we were asked to count, because that was the measures that also ceased being counted when the COVID period came in. You'll see that we were still not where we needed to be in terms of that, and we had people waiting for longer periods than they should have been doing. Now, there is an explanation set out in there, and we had hoped through the introduction of the Independence at Home framework, which is a framework that gets domiciliary care providers working with us in a different way, and with the framework for care homes, we'd have hoped by now to have seen the impact, positive impact of that, so that those detox figures would have reduced had the situation remained the same. But of course, we can't demonstrate that because the discharge to assess process came in with COVID, and we had to get people out of hospital very quickly. So in fact, I don't think going forward, and I'm sure if Corinne Edwards are on the call, she'd be able to agree that going forward, the measure on the discharge to assess, the delayed transfers of care, won't be measured in the same way anymore going forward at all. And the government have already said that to us, that what they'll be looking to do is look at our reablement service performance, and they'll be looking at our assessments performance. So we do know, as it says in this report, that a lot of the delays were down to home care, so domiciliary care, home care services, or access to reablement services. And we have been working closely with, commissioners have been working closely with Virgin Care to look at the reablement arrangement. But I have to say there is quite a lot of pressure still on that service because of the new discharge to assess arrangements that came in from the 1st of September. And I'm not sure that's going to be as smooth as we would like it to be, but I can assure the panel that actually all colleagues across the council, the CCG and Virgin Care are looking, and with the provider services, other provider services are looking to try and improve that and to try and make that more responsive. So we later go on again in the report about the delayed transfer of care and around direct payments. And then I want to draw your attention particularly to the local key adult safeguard social care performance indicators that aren't measured as part of the national reporting. And that's one of the things that we've kept a keen eye on, both as commissioners across the CCG and the council, but also from the panel, and particularly Councillor Appleyard, has been around the number of social care assessments and the timeliness of those. And you will see that actually, despite the assessments taking longer, despite them having to take place in a different way, we have seen a slight increase, but actually Virgin colleagues, I would argue, have done well in terms of making sure those assessments are done in a timely way, and they have looked and done a risk stratification process for anybody that is waiting. And you'll see that actually those figures are better in February than they were in December 2019. So things were improving, albeit that they slightly did increase the length of the wait. From a review perspective, we changed in January 2020, we changed the way that reviews were being measured. And you can see that the figure did dip there if you look at figure 4. Now, I have to say that I think because we're needing to prioritise the number of people that we see and the way that we deploy staff, which the council are supporting, council and CCG are supporting Virgin in doing, reviews might be one of those indicators that slips further, because actually we need to concentrate efforts on assessments and doing the risk stratification and prioritisation of people. So we need to keep a watching eye on that during this period, to be honest. And Virgin colleagues would agree with that, I know. Occupational health assessments, we'd already reported to you that the performance was not where we wanted it to be in terms of those assessments. I must apologise because I don't know why on page 10 it's got in bold error reference source not found. I don't understand that because figure 5 is actually below, so I'm not sure how that's even happened. But you'll see that there is a recovery action plan in place, and we are monitoring that on a monthly basis. I have to say as well that Virgin did contact everybody, I believe, that there with an outstanding occupational therapy assessment was needed, and some service users during the COVID period had asked for people not to go and attend. And you can understand when people are shielding that that might not be the priority for them, but of course it impacts on the delivery of the service and how that looks like it's performing. But on a very positive note, at the beginning of September, Virgin had employed a new full-time permanent occupational therapist and had also employed a full-time locum occupational therapist. And the thought was that they will start to address that waiting list. But as I say, we will need to keep a watching brief on that. I've already talked about the safeguarding adults data. And in terms of the performance from a health perspective, you'll see that some of these figures, understandably, are in terms of, for example, the referral to treatment time. You'll see that their performance as in 2019-20 was very good. The performance now against some of these figures has obviously dropped, understandably, given the COVID period. But even when you look at the majority of these, if you look at the referral to treatment time And if you look at the 6-week diagnostic standards, you will see that Virgin have continued to perform at a better rate than the national average, and in some cases a better rate than other parts of the CCG footprint across Wiltshire and Swindon. So I think they should be applauded actually in terms of keeping to track with some of these. In terms of continuing healthcare, the difficulty with that particular piece of performance is that, as I said at the beginning, the reporting on continuing healthcare ceased because continuing healthcare assessments for new people looking like they were eligible stopped from March. But so then what happens is that it only takes a couple of people where the figure might not look as it should look for those that are doing reviews. And I think that is part of the explanation for why that figure doesn't look as it should. But the team are back. They had been redeployed during the COVID period to help other parts of the system, but they are now back on full force because the new continuing healthcare assessments started again on the 1st of September. In terms of, there's a section there on local reporting on health services delivery that goes into more detail, and that's in the appendix that you will see at the back of the report. In terms of quality, just really quickly, the complaints have remained stable and level, though you'll see during the COVID period, the number of complaints have actually reduced in comparison to earlier in the year. And in terms of work on pressure ulcers, Virgin Care actually did an audit on 3 particular cases to look at what was happening there, and I'm waiting for the outcome of that. In terms of stories of difference, we put these in because I think it's really useful for the panel to help see some of the work that's taking place and the actual impact that it has on the person. And I'll just, without going through them, just ask you to particularly read that occupational therapy one, which I think is a very, very good outcome from somebody being in a care home, not being very happy, and being supported with reablement, first response occupational therapy, and through getting the right disabled facilities equipment put into the home so that that person could remain at home and in a happier place. So the quality of life for that person is, as you would expect, improved. So that's just one story of difference that has been made, but there are others there that you can read. Very positive feedback on the Compassionate Communities Hub, as you can see here. So I'm going to pass you back to Claire now to talk about workforce and transformation, because I know that they were particular areas as well as performance. The workforce bit was of particular interest. So I will pass you back to Claire.
Excellent. Thank you, Les. So we're in section 8 now, which is the workforce. Under 8.1, this is a table that outlines from April to July 2020 headcount against whole-time equivalent position, and it's showing a decrease of 12 whole-time equivalents, and this is in line with the transformational change through creating efficiencies within the contract, and that's as described from the original transformation of the contract. Under 8.2, that is sort of retention, if you like. It's the levers analysis of Virgin Care colleagues. And the table there demonstrates an improvement in staff retention. So you will see from the 2019 position in July, I beg your pardon, total of 54, to the July 2020 position of 48 levers. So that's a positive move if you take a year-on-year comparison. Under 8.3, we have reported Virgin Care's activity, if you like, or performance around the effective management of sickness, and that's both long-term and short-term sickness. Virgin Care sickness rates during COVID have been low. And that's around the work that they've done to really support colleagues through the pandemic and make sure that colleagues are supported in a safe and constructive way, and their health and well-being put it paramount as well to manage people through that process. The table that's listed there, if I can just draw panel's attention to the fact that what has been included there in the sickness is any Virgin Care colleague who has been absent through COVID-related self-isolation or those that have been needed to shield. So I think it's a really important remark to make there, because all organisations, if you like, will have a level of staff, isn't it, that's having to take some absenteeism due to that impact. It's a positive trend, is what this table demonstrates, for both July and June. If you do the year-on-year comparison from 2019 position to 2020, demonstrated there's a positive improvement in terms of the effective management of the sickness rate. Moving on to 8.4, and Councillor Hardman, I know that this is an area that you'd raised some particular interest in, so I will endeavour to answer those as I take you through this area of the report. In 1920, Virgin Care did report in the last Scrutiny panel report the improvements in the effective deployment and management and completion rates of their annual appraisal, and that has resulted in 80% of staff having an annual appraisal. Now, what's been really interesting is, due to COVID-19, Virgin Care have taken the innovative step to actually approach, if you like, some of the process towards annual appraisal and performance management of their colleagues in a different way. And that's seen the introduction of the Hey conversation, which is the "How are you?" is a very natty named conversation. This is, in fact, not to replace any annual appraisal. It's there as a supplementary activity, and it's being used as a midpoint review to talk about the, how are you, what is happening with your health and well-being, what are your longer term aspirations, what's happening in your role. And the feedback has been very encouraging, in as much as it was introduced as part of the sort of COVID response to release, if you like, some of the pressure off of those service areas. But actually, staff have found it wholly really engaging and a positive way to do. So that's going to now be taken forward, is used as the midpoint review, but again, not to ever take away from the fact that staff will still receive an annual appraisal. Moving on to 8.5, that's with regard to colleague satisfaction. And again, Virgin Care have reported that they continue to make efforts into ensuring that colleague satisfaction is reported, and actions, importantly, are taken in to address anything that comes out of that survey activity. Initiatives that I feel are important, just to get on the focus, are listening events, regular partnership forums, increased in visibility and access to training opportunities, and service-specific newsletters, and a regular sort of weekly managers briefing. And that sits alongside all of the usual annual sort of survey or collection points that I know that panel have received reports on previously, all of which is aimed at increasing engagement and colleague oversight. And important as well to draw panel to the fact that each service now within Virgin Care also develops their own have your say action plan. So not only is there an action plan about how there's if you like a corporate response to addressing some of these issues, but making sure if there's anything that's service related, those are drawn out and giving the managers of those services the opportunity to work towards addressing those key activities with their teams. With regards to have your say, that is the annual colleague survey, and this year Virgin Care are planning on undertaking the survey as of the 28th of September 2020, with a closing date of the 16th of October. And what's been agreed between the Joint Commissioners and Virgin Care is that at the close of that survey, Virgin Care will obviously undertake a detailed period of analysis and review and evaluation, and then bring to Joint Commissioners the intended date is January 2021, that some of a report, if you like, giving us the review and the analysis and the evaluation, coupled with what are the pertinent points and key actions that will be taken moving forward. So when we do the next panel update with regards to the commissioning report, that's another key area of focus if you would like us to follow through to keep that area of focus on the workforce development. I can see you nodding, Councillor Hardman, so I will make sure that that's included. And of course, visibility of the senior leadership team did come out previously with Virgin Care as something that needed improvement. And of course, I think it's important that we recognise that some of the usual things that would have been done previously, i.e. walking into service areas, walking the floor, isn't it, holding face-to-face engagement activities, have not been as easy to deploy as previously. But like all organisations, what Virgin Care have done is hold virtual engagement events. So for example, what's been cited in the panel report is the visibility of the senior leadership team through hosting a regular sort of opportunity for managers to dial in with Kirsty on a regular basis and receive updates, and that's also supplemented by a partnership forum. The final sort of survey in terms of this section I'd like to draw your attention to is the social work and the health check survey. That is due to happen, and that happens on an annual basis within Virgin Care, and that's going to be deployed within the October and November time. So of course that's been led by Virgin Care's principal social worker. It will have again a period of review and evaluation, and any key person actions we can make sure are picked up in the forthcoming report. In terms of engagement, and that's under section 8.6, like I've alluded to, I think we all have to understand how differently we now engage with one another through our various service meetings or governance assurance meetings. And it's just to draw the point again about managers and senior leadership teams actually being drawn together virtually on a weekly basis to have a briefing from the Virgin Care CEO, from Kirsty, and to keep everybody communicated on what Virgin Care are doing as a system player and how that impacts on services. The last section under workforce is section 8.7, and that is with regards to recruitment. And what we've detailed in the report with Virgin Care colleagues is some of the recent activity within the last 4 months, whereby 96 adverts have actually been posted, and that's had a good turnout of attracting 435 applicants. And from that recruitment pool, 63 offers have been made, and 29 of these offers are already going through the due diligence and the onboarding to actually bring these staff to join in the organisation. Some of the key areas of success for Virgin Care have been in attracting staff to come and join in community nursing and community hospitals and estates. And actually, I think what's important that we recognise is that the calibre and the consistency of the applicant is improving. I think that's to be applauded, because I know that Virgin Care, from the last panel report that's come through, they've taken huge steps to widen the engagement pool and take different steps to attract people about the benefits of not just working for Virgin Care as a private, but actually attracting people on the basis of a fulfilling sort of career, if you like, in the health and the social care sector. But that does not mean that there are still not some areas for concern that need to be addressed, and those have been cited in terms of Band 5 physiotherapists, social care occupational therapists and social care colleagues, and we do know that those as a sector are difficult to attract and employ that calibre and those individuals to come and join our services. And that moves me swiftly on to section 9, which is the section with regards to transformation. In the last Commissioner report that we did to Scrutiny panel, we gave an overview of the key priority areas in terms of transformation that had been agreed with Virgin Care as part of the Your Care, Your Way. I've put together with colleagues quite a detailed table, and I will not take colleagues verbatim through all of that, but I think it's really important that we continue at these junctures to have this oversight at 6-monthly intervals to look at those with the original aspirations of transformation under a person, not a condition, a single plan, a focus on prevention, and actually highlight in quite a simple table some of the key activity that Virgin Care have been undertaking. So that large table gives a flavour of all the different transformation activities that Virgin Care continue and have a focus on, that always takes us back to, are they meeting in terms of those key transformation priorities what was asked of in terms of the Your Care, Your Way? It was an ambitious plan. That leads me on to section 9.2, and that's a more contractual relationship, if you like, in terms of what happens under the banner of transformation, and that is with regards to the Service Development Improvement Plan, the SDIP. What I've done here is included for panel the outcome of the 2019-2020, so that's contract year 3, and that's the totality of the SDIP milestones in last year, and we broke them down by quarter, and each quarter we worked with Virgin Care colleagues to give a narrative between the commissioners and the service colleagues that are owning that level of transformation, and we RAG rate the effectiveness of that. So I've now been able to put for panel the whole of the 1920 output. Quarter 4 is what is new to panel in terms of this report, And what it shows overall is that there were three milestones not achieved. In a moment, I will take you through and give you assurance that those have now been achieved. What we were talking about is a reporting period that takes us to the end of March, but actually I will take you through and give an explanation of those and some assurance that they've now been achieved. But overall for transformation in 1920, 69% of the milestones have been fully achieved, 17% partially achieved, and 14% not achieved. The three milestones that I'd like to draw panel's attention to are those in relation to the integrated care record in Q4. But however, overall, if we go back to the Your Care, Your Way priorities and what's been significantly delivered over the duration of the contract thus far, taking us up to year 4, there has been significant progress in ICR development. And we, Virgin Care, have now successfully delivered a live integrated care record in year. This now has all Baines community data, adult social care data, GP System 1 data, and that's 23 out of the 24 GP practices, and RUH hospital data. And this integration has allowed practitioners to start to have that appropriate visibility over individuals' care records and how we best make decisions about the care plan that best serves that individual moving forward. Some of the first users of this have been social care practitioners and community matrons, and that's been especially helpful during the COVID-19 pandemic and beyond, because what it's actually allowing us to do through the ICR is have alerts and notifications that pop up and make it very clear if an individual is actually a COVID-19 patient or has tested positive. In year, the ICR has been developing technology, ability to provide risk stratification, and also population health analytics. And it's that population health analytics that's going to be so vitally important moving forward for the future identification of those vulnerable groups. And this will remain the technical aspect and the analytics is a key focus for Virgin Care moving forward in 2021. Just to draw your attention back to what I said about the Q4 ICR, is that those milestones have now been achieved, and I think it's just really important. They are, a small minority of milestones, and what's actually now happened is that even though they weren't delivered at the end of Q4, those have now been included and delivered, and this has been the development of case studies, the implementation of a One Population Health report. That's what was the ask. And they were initially, we said we've gone over the Q4 period, but I think it's really important that we celebrate the fact that what's now happened is that we've actually achieved 5 population health dashboards, and these are being developed, and the integration of the RUH data successfully in system as of June 20. So that's what's caused the delay, and there's been some sort of galvanisation and making up of some of that time. With regards to the SDIP for this contract year, so year 4 in 2021, we would normally have already agreed that contractual sort of agreement of that high level transformation and what's going to go into that SDIP. As I said at the start of my section, we've had to do contracting slightly differently this year for reasons we all know and understand. So at the moment, that's one of the schedules that I will be working with Les, other senior officers and Virgin Care colleagues to agree the high level transformation that will be included in that SDIP and how we will work towards that, given the fact that we are now a little bit later in the year than what would normally happen. So that's the end of both of my sections, and I'm just going to hand back to Les, who will take us through the finances and the conclusion of the report. Thank you.
Thank you. And Vic, I'm conscious of the time, so I'll be very quick now. So just in terms of the finance, as we reported at the last report, Virgin Care did come in 0.7 million overspent in 2019-20, but as of the year-to-date position, we are looking like they might come in on a balanced budget this year. But as I say, it's quite early on in the COVID period. They are working to find mechanisms to help with trying to support the council in its financial position at the moment, and we're working very closely with Virgin colleagues to do that. And I suppose really that does conclude the 6-month update report. It is very detailed, but it's been Virgin Care has been particularly important to this panel and to people in the public that have come and asked questions of the panel. So we've provided the level of detail in order to provide assurance. I wonder going forward whether, because we obviously don't do this level of detail for other providers, but I'm conscious of the history to this and the rationale for it. But going forward, would it be helpful to just do an area of deep dive for the panel, of particular focus, to not go through absolutely every area in detail again? I'm just, I'd take a steer from the panel as to what you would like really going forward.
Very encouragingly, but there are just a few parts that cause concern. So if we could go with just those particular areas, I think that would be appreciated, because it takes up such an amount of time to go and trawl right the way through when there's nothing wrong. All we need, we just need a general assurance that everything else is going okay, and some of it beyond what was expected. But those, with things like reablement and the financial position remains a concern as well. So if we could just concentrate on those. Now, I've got a number of speakers, and it's just whether how much they want to make, because I'm also getting notification that people need to leave at 1 o'clock and we're not part way through the agenda yet. So Kevin, you wanted to say something. Do you still want to make comments?
Well, very quickly, please. Yeah, 3 points, Leslie, if I may. First one is I'm assuming from what you've said that basically it's a good performance and you don't really have any key concerns as a commissioner. And I'd like you to confirm or otherwise, or if you do have any key concerns, let us know. The second point was on page 43 about, sorry, that's of the whole pack, of the Children's Audiology Service that's been impacted heavily, and how has that been mitigated at the moment? Is it still on its way back, or is there, do you know where that's got to, even if you only have to send us some written reply? And the last little bit was on page 61, again of the pack, the last paragraph about before the next steps, implying that possibly is that with the finances, either there's going to be a cutting down of the Virgin services, or will there be something else from government, or you're waiting things from COVID support or something in terms of working out the best way forward?
Okay, in terms of the performance issues, we're not there with absolutely all of the performance. I think the report indicates that we aren't there with all of it, and we are working closely with Virgin colleagues, the commissioners are, to look at how we can improve that. Some of this is in Virgin's gift, some of it isn't, and it's down to the state of the market as well. But I will get you a written response to that bit, just to confirm, Kevin, so that you can actually have the confirmation of any issues that we are concerned about. In terms of the OIS, I'm going to need to give you a written response in terms of that, because I haven't got that detail to hand, I'm afraid. So apologies for that. In terms of the finances, in terms of the contract value, there isn't any indication at this moment that the contract value will be reducing, but what we need to be doing is thinking about the types of services that the types of services that are included, the type of support that's included in our placements and packages, and is it in the right place at the right time? So that's the piece of work we're doing with Virgin around trying to look at that and do things positively. We're also looking at some of the subcontracts, and I've got a meeting just this afternoon with colleagues, just looking at are we using the subcontracts in the best way that we can. We're doing that with Virgin colleagues, but also with the subcontractor services themselves to look at that. So this is about looking at the services as one system and what's needed, and where do we need to make changes. And in fact, the 3SG group have come very positively and said, we need to work together with you on this to identify how we can help. So we are really trying to approach this with Virgin, but with the whole sector in the spirit of co-producing and doing the changes where we need to do that together. This certainly isn't a case of just making cuts in that way, if that makes sense. We do want to do this collaboratively, and Virgin are very much in that space with us and with the CCG, but with all providers as well, because they've been proactive in terms of coming forward. Does that answer that question in terms of that bit?
Yeah, thank you. It was really that sort of, I understand the financial constraints, different things happening, plus COVID and the implications of finance there, and whether anything else hopefully will come from government as well to help you out.
Ruth.
And we don't know at this stage, obviously.
Ruth, did you want to make any?
Yes, hello. Now it was a great deal of detail, so thank you for the report. However, on I think it's page 54, which is point 83 about sickness, long-term and short-term sickness of colleagues. I just would like a bit more information if possible, now or in writing, if not later then. What additional support for Black, Asian and minority ethnic colleagues have you put in place?
I will pick up that action and I will have to go back and seek some further assurance, but I can make sure that that comes back to you in writing with a further update to address that.
Jess.
I think Liz is before me, Chair.
I am. Firstly, Claire, both both Les and the other lady, Claire, I think. Thank you. Yeah, it is Claire. Thank you for such a thorough report. I think it is good that you select areas maybe to highlight on. There's an awful lot of very positive things that are happening. A big thank you for answering most of my questions. Thank you very much. It's good to submit them in advance, so it speeds us up a bit, but thank you very much indeed. And a really big well done for Virgin for leading the 3SG. I am a volunteer with them. It's embedded in our area out here, Porter, Midsummer Norton, Radstock. So really well done for what you're doing. It's just a written response really, and it really kind of leads on from what Kevin said. It's good to know that you probably will achieve a balanced budget, but how are you going to achieve that? Well, is it going to mean some of your services are going to be discontinued or cut back or whatever? But a written answer will be fine for me for that. Thanks. Thank you.
So Jess.
Thank you. So my question slightly leads on from the one that Kevin asked earlier on. I also agree that the general tone of the report is very good and sounds very positive about Virgin's performance, which is great. What I wanted to ask was how or if Virgin gather feedback from their service users, so from the patients that experience Virgin care, and also from other partners in community care, including care homes and GP surgeries, that kind of thing. It'd be good to see some sense of feedback from other people.
Okay, there is, in terms of the quality schedules, Jess, there is a number of mechanisms by which Virgin do gather that feedback. And so we can provide a written response on that as well. They won't be dissimilar to the ways that all providers, I have to say, and I think it's important that we don't separate Virgin out from all providers in that sense. All providers are required to do it. So we will provide the information, of course, but it is in line with what everybody else is doing as well.
Andy. Andy?
Seems to have frozen, Vic, I think.
Yeah.
It's a shame.
Right. So with the absence of Andy, I'm not going to take any more speakers on this. I think the panel are of the opinion that in the main, the Virgin report is very encouraging. There are some elements of concern. When we have the next 6-month update.
Back, by the way.
All right, you're back in, Andy?
Yeah, I'm back. So I don't quite know what happened there. It's bizarre. Do you mind if I ask my question?
Yeah, sure. Go ahead, please.
Okay, it's a very short one, I hope. I was listening very carefully to Leslie's response to the delayed transfer of care table on page 45, which I know Liz is also concerned about. And I was quite happy with the response until she got to the line that said the delay in transfer has changed on the 1st of September. And I thought, oh, because you had plans, and now it looks as though your plans are sort of not perhaps as effective as you feared you hoped they could be. So I don't mind if you want to write to me about that, but what are the changes that you are concerned about?
I wasn't meaning that. I'm not concerned about Virgin's response in terms of that. What I mean is the way that we report nationally in terms of our historic reporting of delayed transfers of care, that is changed from the 1st of September. We stopped already reporting the DTOC reports from March, but now the government have confirmed that we're not going to be reporting at all in the same way that we were. So those figures are now going to be focusing on they look to be, that might change again, I need to qualify that, but look to be thinking about reporting on reablement activity and performance and assessment activity and performance. So they're the reports are going to focus on a different aspect, if you like. So we won't be able to compare like with like, because it won't be there to do it. And that's a national decision, not a local decision. But that doesn't mean, my point, I think that I may not have articulated correctly, is that from the 1st of September, the discharge to assess process has changed to a 6-week period of funding. I can give more detail on that if that's what's needed, but we've had to look at different ways of managing the delayed transfers of care and work very closely with Virgin colleagues and with the RUH and with Avon and Wiltshire Mental Health Partnership Trust into how we are going to take that forward. So there's been a system change from pre-COVID to mid-COVID to now from the 1st of September. We're on our next wave of change. And to be honest, services are being so responsive to dealing with this with very little time to implement. But it's from a performance perspective, we won't be getting the data because we won't be collecting it in the same way. That's all I meant to articulate. But I did say that I was concerned about reablement having the capacity to cope with the flow, and that is something that as a system we need to look at. And I think Virgin colleagues and the CCG would echo that were they speaking right now. So we do need to just closely monitor that, and that is something that both the council, the CCG and Virgin are doing.
And that's what we would like to see when we come back with the reports in 6 months' time. That together with the financial position, and we need to be specific. The elements that are doing well to date, I don't know that we can have just a one-liner assurance that that's still happening, and then we can concentrate our efforts on what isn't working so well. Now, I'm in a very embarrassing position that I've only got 5% battery left. So I might have to hand to you, Michelle, just to pick it up. Okay, so we're scheduled for another. And thank you very much, Les, and also thanks to Claire for contributions. Very comprehensive summary of the Virgin to date, and in the main very encouraging. So I'm going to move on then to item 12, children's.
Sorry, before
yes?
you go on, you're asking me to pick up if your battery goes, but I actually need to leave in 13 minutes because I've got another meeting at 1 o'clock, unfortunately.
Right, well, do what you can, and then we'll have to carry it over onto the next agenda.
May I suggest that we do that anyway, because I think we've been here a long time now, and I appreciate that we've got officers here waiting to present their reports, but I think that to be fair to them and to be able to ask the questions, could we not schedule another meeting in between now and November to
Mark
items?
Mark, is that in order?
Hello, Chair. Hello.
Yes.
It's down to yourselves, really. You've been going quite a while now, and if a certain number of members need to leave,
and you can accommodate that. You can support us in that.
I guess it's easier these days being virtual, but
right.
Obviously everyone is as busy with work as they would probably normally be. I don't know if anybody that's sort of listening out there has got their remaining reports time critical. The one that stands out is the annual report, really, of the Safeguarding Partnership. I don't know if that needs to come sooner rather than
Les, can that be guided by you?
Time, let's say.
Yeah, thank you, and thanks for the opportunity to answer. I'm happy for that to be delayed. I appreciate, Michelle, what you've just said, and in fact, we've got officers sitting waiting, haven't we? But it's also a bit disheartening, actually, when people don't get the opportunity to talk through and for yourselves as a panel to be able to ask the questions. So if I'm happy for that to be delayed, but I would, because I think we've got quite a full agenda, or looking like there might be a full agenda for November as well. So I think one in between, if you are allowed to do that, if we were allowed to do it, would be very welcomed, actually.
Right, then I'm going to lead that. That's what we do, because we won't give, we've still got a considerable amount of the agenda to do. We'd never do it, and we'd lose members, and so the contributions aren't there. So I'm going to endeavour to bring the meeting to a close now, and then for item 12, 13, 14, 15 and 16 we have an extraordinary meeting to deal with that. So Mark, if I can put it on you to find a suitable date, and hopefully, Liz, you wanted to say something?
I'm sorry to interrupt again, but I think Councillor Hodge wanted to say something about the music situation, because she is substituting and she will be here next time round. And I think it's a really good idea. Michelle, well done. I think as long as it's on a Tuesday, please, but I think it's a good idea to have another meeting. Yeah.
Lucy, did you want to make a comment?
Yes, only it was in relation to the music hub item, and I'm a substitute, so I wouldn't be attending next time. Am I able to say something briefly in relation to that or not?
Yes, please.
It's just I just quickly that I read the report. I've been my children have been users of the service for 6 years. All three participate. They're grade 8 on all their instruments now, so they will be moving on. But I would like to, when I read this report, I recognise the points that it's making, but I do want to say again that I think this is a service that is incredibly well received. It has been, I volunteer and I try to raise money for it, selling penny chews in the breaks for the with the tuck shop, and I kind of don't recognise the kind of I find it hard to imagine which elements of the service can be lost. I see the points about diversifying and reaching other members of the community, but I think the statements that can deliver financial and time efficiencies that will support improvements, I would like to see the consultants report really, and I'm just flagging up concerns about elements that are delivered at the moment that could be lost to change it in a different way. I think it is diverse. I think although my children don't just benefit from classical music, there's a wide-ranging music opportunities. I don't think any of them could be reduced, and I think it's open to state and all school children when they get to a kind of they take off with their instruments. This is really the only place for them to go. There isn't another alternative, you know, unless they're at a national level like the National Youth Orchestra or the national services. It's an affordable service, and it's really has been providing the core opportunities to players groups. So yes, I do have concerns about the direction it's taking. The second point I wanted to make is about online tuition. I think online has, I noticed the comment that it would, there's been a positive response to the online tuition, and it might be a part of the music service moving forward. And I mean, I understand that the service has stepped up to the plate and has maintained services through COVID providing online, but it's not optimal on online music lessons, and I would just hope that the majority of them return to being live music lessons in the future, and that isn't from our own personal experience. We have 9 lessons a week, and every single one of those teachers has wanted to revert to live lessons as soon as possible. So it's mentioned as a possible way of reducing carbon footprint and being retained as part of the service. Of course it could be retained, but I would be concerned about too much tuition going to online in the future. That's really all I wanted to say. It's a very
Lucy,
received.
thank you for substituting. Your points will be recorded, and we'll actually we'll answer them when we deal with it as a full issue next time on our extraordinary meeting. I've just got a note through now that we should express our good wishes to Mike Bowden, who has resigned as director. Certainly, there's been opportunities for us all to make our feelings known to Mike, that he was a valued member and highly respected. Sorry to see him go, but we will make a record of that. And so I think it's appropriate now that we bring the close. I'm down to 3%. You see why I'm cornered here, just so I can bring it to a close. Thank you all for your contributions. And next time I'll remember to bring the charger with me. Hopefully I don't need it, and just for the sake of all of us. So thank you all very much. Thank you.
Thank you. Goodbye, everybody.